This conference will now be recorded.
Okay, so we're back from our 10-minute break there. The scene size up, and it's not any different from anything else. Information from dispatch, may indicate the mode of injury, but believe it or not, I get called for someone who is in respiratory distress. We've got a Delta level. You gotta need a medic on it, and you get there and no, we got chronic back pain. So don't believe everything you get from dispatch. They're only passing information that they're getting, hopefully, from a competent caller. Try to identify the focus associated with the motive of injury. Right. So things change, as I said, on arrival. The primary, stay alert to primary, secondary injuries. They're ones that are caused by the injury itself, secondary to joints as the result of after the initial injury, we have something else that got hurt. Consider what injuries the MOI would lead to. So just be aware. You're not going to deal with one injury, maybe more. Focus on identifying the management of life-threatening. So are we worried about someone who has an open tib-fib fracture? Or are we really worried about, gee, the airway's closed and they're not breathing? I don't care if they're pumping blood out, but if they have no airway, then we got to get the airway open so they can breathe. So treat the patient according to the level of considerations, ABCs. As much as we are talking here, but you're never really working by yourself, or you shouldn't be working by yourself. There should be a team there. There should be a partner in your ambulance, or if you're within a fire engine, there should be an engine company there. And so, you might even need the assistance from a bystander or a police officer. Depending upon what program you're going in, you just grab help on some of these things. Many times on scene, hey, cop, can you please go on over there and get me all the list of all the medications, because they don't have a list of them. So they have to go search, get the box of medications, and please print legibly on the what medications they have, so that I can look at them real quick and see what I may or may not need to address. So treat the patient according to the level of the ABCs, and then we look at addressing significant internal, external bleeding. Again, internal bleeding, all you're going to be doing is treating for shock and maybe immobilizing if it deals with joints, things like that, immobilize the joint to reduce the restrictions of the movement and pain, and also bleeding, and apply ice to that location. And we all know about AVPU already, I presume, right? He's already gone through AVPU, beginning of the book. Ask the patient about his or her chief complaint. That's a simple question, but does not get asked a lot. Why did you call me here today? What is the problem that you need me to call me now? Not, I have chronic pain for the last 6 months. Why did you call me now? Here is, okay, you fell off the roof, but where do you hurt? There are a lot of injuries that could have happened when they fall off the roof, but you want to know what is their complaint, and then you can address that and search for other possible problems. Administer high level of oxygen. They say this. We also say that you don't get necessarily someone who's oxygen if they're 93 or greater percent. You have to get that as part of your vital signs. You're not going to do negative by giving them 2 liters of oxygen, right off the bat for your trauma, because they're probably, anxiety, the trauma, they might need a little bit extra oxygen. But we don't want to snow them with too much oxygen also. Non-rebreather, again, go with the reading of SpO2. Right? Need that to help identify where they are. BVM, non-BVM, all of those people are conscious or the altered mental status that you actually have to do something for. You know, ask about the mode of injury. We already know. We want to know that in our history taking of that, what actually happened. If there's a significant trauma and multi-body systems affected, the muscular injuries, lower extremities are lower priority. So if you have a significant multi-system trauma patient, what are the things that are going through your mind? What do you as an EMT need to know or make decisions on? Can I have your input?
Priority, so like transport,
Right?
oxygen interventions, like shock.
Yeah. Yeah, we want to think of, do I have the necessary resources on hand to give the care this patient needs? Do I need to call for ALS if it didn't already come? Right. Do I transport this person to the local hospital or do I transport them to a trauma center? Maybe I need to call MedFlight. All right. So if this is a critical patient, you know, the local hospital is a level 3 trauma center, you know, or level 4, and this person is going to need multi-system workup and treatment. So you call for, see if the person can get flown to the appropriate level 1 trauma center. Believe it or not, that's not cheap, folks. You are kicking up a bill of anywhere minimum 20, probably more like about $60,000 for that flight. Not all insurance companies cover it. So it's a significant question. Scene time should be not wasted and prolonged with that type of injury, the multi-system splinting and things that we might just do it en route or see what we can do stabilizing things. All right, always airway breathing, fractures and sprains do not create airway problems. So that's, particular, should be a moot point unless there's something else going on. Circulation, determine whether or not the patient has a pulse. Right? You actually have to feel it. You have to touch a patient. And you want to touch not only the distal to the injury site, but compare it to the other side, the other person's. All right. So hyperperfusion, bleeding problems will most likely be a primary concern, but, if you're doing a quick trauma survey up and down the person, you might have your partner, hey, take care of this bleeding in here, and I keep on going down, keep on going, do all the assessment on that. Note, your skin is it pale, is it cool, clammy, capillary refill, slow. Is your patient in shock or going to be in shock if you don't do something soon? How many people actually take normal body temperatures? Believe it or not, we have a major problem. Most of our trauma patients are coming in from the field who are hypothermic. They're cold. And this past winter, if you're dealing with a car accident out on the road, the person might have been in a warm car, so they got a light jacket on and clothes. Now they're laying down in the slush and the cold on the asphalt. They're there for 10 to 20 minutes while you're waiting for you to show up, and then another 20 minutes for you there. That's everything of trying to undress yourself a little bit and lie out in the snow for 20, 30, 40 minutes. It's a eye-waking experience of how that goes. So treat for body temperature. Okay. If muscular injury extremities, they must be initiated and stabilized. Yeah. Transport decisions, we already talked about in regards to that. And do you decide whether to treat or go? And it's now we say we'll treat them eventually if we're going, but do we need to do something right now, or can we get them in the, or do we, do it en route? What do we have time for? So backboard is something to scoop the person up on and put it in, or some people will use a scoop stretcher to that, pick the person on up. We use now backboards mainly for extrication, get someone out of the vehicle on that. and then put them on the stretcher and log roll them off of that. History taking. And it's great. Try to get as much history from the person if they're alert and oriented and able to communicate, or there's a family member. Alert to significant injuries because if they have osteoporosis or they have calcium deficiencies, things like that. And these are things to note. Obtain sample history. I presume everyone has already gone through that. Has he, or am I assuming something about the sample history that you haven't done that, or you have?
No, Dave, we've covered that.
Okay, thank you very much. All right. So it depends on the seriousness of the injuries, what you're going to do. I gave Kevin a little bit of a single piece of paper. One is medical assessment, and the other side is trauma assessment. And when you're dealing with trauma, basically you want to make sure spinal immobilization, whether or not you do it manually or you don't need it, mechanism of injury, some general initial impressions on that, and hit the level of consciousness, the ABCDs, and your GCS. And there is another trauma alert that you may need. And at that time, you get your vital signs, you do your DCAP, BTLS. So yeah, it goes all along with that. Make a decision with or without time to make decisions with good history, or you might have no history whatsoever. And if you have the time to ask all those questions of onset, the OPQRST, questions, yada yada yada, that goes along with it. That's great. A lot of times we don't get a chance to actually do that. If you have someone else there to assist you, a third person or whatever, because maybe you and your partner are working this person, to have someone write down the information for you as you go along here. Secondary surveys, okay? Secondary surveys a lot of times are done in the back of the ambulance because of the critical nature of the person. We have to worry about the primary survey, the ABC, to get that taken care of, and we might not get to the secondary survey to maybe halfway through the transport to the hospital if there's still things in the the primary survey that we need to address. We always talk about BLS before ALS, and EMTs save paramedics. Paramedics get tunnel vision in regards to I gotta get the IV, gotta get this med and that med. Oh, by the way, you think maybe the EMT says, you think we should put him on oxygen? Oh yeah, and it's very important to work as a team and we need to address the ABCs before we get into the secondary physical examination. But if significant trauma is likely affecting multi-systems, starting with the secondary assessment of the entire body, there are ways to actually do this. You head down, head, chest, abdomen, pelvis, one leg, come back to the extremities, flip the person over, back to ding ding, and then flip them back on over, and you should have identified. If you identified anything life-threatening during that real quick assessment, you take care of this, and you keep on going if someone else can take care of that. So that's what we're looking for. When lacerations are presented in an extremity, open fracture must be considered. Bleeding controlled dressing. Again, dressings are sterile. And wraps or bandages are not necessarily sterile, but dressings are what's sterile. We want that applied over to the open bleeding of a possible fracture. You have to assess. Maybe it was something else. Maybe they got hit there, but they didn't actually break it. If your assessment finds no external signs of injury, ask the patient to move the limbs. All this stuff is in your assessment, the secondary assessment on that. You get the time to do this and work you through. Explain to the person what you're doing, why you want to do it, so they can assist you and participate in their treatment. This is very important when you get into adolescence. they're concerned with their bodies and things like that. And they get in a motor vehicle crash, and you're sitting here and you're cutting all their clothes off on them. They don't understand what the heck. Hey, this is my body, and so and you are invading them. So you need to express why you're doing this to the person to let them understand, so they don't get the the feeling that you're raping them. So it's important to explain to your patient what you're doing if they have a level of consciousness that can understand that. So we've gone through all the looking for the DCAP BTLS aspect of that, and that's pretty much, you should really know that in the back of your head. Some of the times you get to the point you do this just in your head, bang, 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 without really thinking about it. And then you go back and try to write your report. What did I do? What I saw. You're not writing down everything you actually saw in your eyes in 10 seconds. It might take you half an hour to write all the things you just witnessed in 10 seconds. Vital signs: determine a baseline set of vital signs, including pulse, rhythm, quality. That means you have to actually touch the person to get that quality of that pulse. Okay, respiration rates, rhythm, and the quality of their respiratory rate. We're not looking for a number, but we want to know: is it shallow? Is it rapid? All that stuff that comes on in. Is it noisy? Is important. It could be asthma, or in this particular area, it might be fluid getting into the lungs. All right. So trending vital signs help you determine whether or not the patient condition is improving or getting worse. So that's why in a trauma patient, we're looking for maybe vital signs every 10 minutes. So we can track that on out, see if the heart rate's going up, blood pressure is going down, the person going into shock. We need to get ALS, to get this some fluids going into this person maybe. Or they're improving. So you got to think of our interventions that we do. We want to reassess those because we want to see if that made any difference to that. So we can put that in our documentation, but also that we can say, hey, the person's heart rate was 150, and now we got them calmed down, and we're treating the bleeding, and now it's down to 80. That shows improvement. Reassessment, repeating the primary assessment, ensuring your interventions are working. Actually, I think I just said that. Reassessment should be performed every 5 minutes. If you're taking vital signs every 5 minutes, you're not treating the patient. I'm sorry. It takes longer time to get a manual BP, and go through all that, and then have time to do everything on that. That's why a lot of people, you should be dealing with cardiac monitors, because they can, once you get your initial manual BP, then you put the cuffs on and you can actually have that take them for you every 5 minutes, and you can look up and see how things are going. Put your 4-lead EKG on, you can see what the heart rate is going, and the SpO2 is there, and as you're working the patient. Or you're going to have someone else to take all those manual. So. Critically ill patients, secure air person on longboard and transport. Longboards are going out of the way. I don't know if you might get them on a longboard and then take them off when you get on the stretcher. But you got to also use the longboard to hold the body together. If it's starting to fall apart, bones going here, limbs are going there, you might need to secure the legs in alignment on the longboard. So. It's not a golden rule to not use longboards anymore. If the patient has no life-threatening injuries, you can take the extra time on scene to stabilize the condition. Remove the patient clothes to look for open fractures, deformities, the swellings, things like that. And initially, you might not have even cut the clothes off. You just brought your hands down both sides of the legs and both sides of the arm, things like that. And if you didn't elicit any pain out of the person, and there is no severity, you not necessarily have to cut all that stuff off. So, and do you really want to cut all of, hey, that was my down jacket you just cut, and now we have down throughout the whole ambulance, or it's a very expensive piece of clothing you just cut that was unnecessary. So, stable patients, you can take your time and get more cooperation from the patient to actually help you remove things to get a closer view on their skin and underlying problems, conditions that they indicate. Check the patient's circulation on the motor functions, the sensations prior to and after splinting. So it's important when you talked earlier about do you straighten out a long bone fracture? Well, because you didn't have any circulation, it's definitely important that you straighten it on out and you want to recheck, see if there is. But let's say you had pulse and then you straighten it on out and now you don't have, that's definitely a time to note and tell to the hospital on your entry note that you did, now you don't have circulation in that extremity. Communication documentation. Again, before you open your mouth on the radio, think about what you're going to say. Gather your thoughts mentally. Take 5-10 seconds. Okay, what am I going to say? Take a deep breath and then call in and give your report. Nice and calm. We don't need someone screaming the radio. Well, the trauma of his legs and this, or ETA's, 5 minutes. No. Look at the patient, look at the information you got, know what your motive information, and you're not, remember, the entry note that you're given on the radio is not a full transfer of care note. You're not giving them every little thing. I mean, they're looking for sex, age, chief complaint, and a set of vital signs, anything else that's pertinent on that, and ETA. We're not getting into all this past medical history stuff. All right? And be very careful in your documentation. Protect yourself from legal action. So that is important. Believe it or not, as far as I'm concerned, paperwork in regards and documentation of patient care is to keep me away from a court appearance. I do not want to have someone sue me for what I didn't do. If I've done something, I've documented the reason why, what the conditions were before, and what they are afterwards, and the patient did improve or they didn't change. So you'll get that in your report writing, and depending on how good you are in your skills of writing reports, it's some people good, some people are not so good, but you need to at least get to a level of competency in regards to all that information. Emergency care, perform the primary assessment and stabilization of the patient's ABC, perform secondary, primary, secondary survey, yada, yada, yada. Always follow standard precautions, okay? Well, we try to. I mean, I go to a call and I got my gloves on. I got a mask on. I even had a mask with a shield on. And for a person who had fallen and hit their head, they had a seizure. Okay. Well, that's the real problem came is that she fell and she hit her head at the base of a lamp. Not really that big of a deal, except this lamp was designed and had ornamentations of deer antlers, miniature deer antlers at the bottom. It just tore her scalp to pieces. And I had nothing but blood all over the place on the floor and all that stuff. I didn't walk in with a gown, but I tried to do as much as myself, not get myself covered. But at the end of the call, my shirt and my pants were all covered with blood. Therefore, I had to change at the hospital into some scrubs and then go back to base and shower and put on new clothes. So try to use your precautions. See what you're going to go into. Are we not doing this? We go that over here. Splinting. Splinting, different types of splinting. We have rigid splints, we have padded board splints, we have traction splints. We all have all these different types of splints that are available to us. All right. You're going to need to be proficient on the ones that your ambulance service or your fire department uses. All right. We may teach you Sager strength, Sager, but you get a hair traction splint from the next place you go to. So you need to up on that. So you have to know what splint to use or what's available. You might be using, for arm fracture, you might be using a pillow from the ambulance, or you might use a SAM splint, how that works and bends around and you can secure that. Or it just might be a padded board splint. So all these things, that you think about when you're using different types of splint, why you use it, what is available. The idea of splinting is to reduce pain, make it easier to transfer, stop bleeding, and stop the motion of the fractured site. Splint will help prevent. Okay, same thing was here. Muscles, skin tearing, restriction of blood flow, excessive bleeding, increased pain, paralysis. They're all those things that we just already mentioned and gone over. General principles of splinting: remove the clothing from the area. So we want to be able to see what you're doing. Note any and record any neurological functions, the status there. Do they have the sensation of touch and feel sharp or dull? Things like that. Remove the patient before, do not move the patient before splinting an extremity unless in danger. The idea here is that we don't want to move the patient, and aggravate the site of the fracture during movement. That's why we like to try to do it there. So we had someone who is sick. We might move them into the ambulance before we, give them some medication or we give them a neb treatment. But in splinting is we got to do it there and then transport. Okay. So we already talked about that. 6, 7. General principles, cover the wounds if there's any sterile dress. So if you have an open wound, let's say you have a laceration to that area where you're going to be splinting, you're going to cover the laceration with a dressing and a bandage to stop the bleeding, to control that before you put the splint on. Okay. And also it'll help you identify while you're doing that whether or not the bone came through or not. So that might be that area, or it might be a different area. The fracture's further distal, and this is a laceration from something else. You need to identify that. What are the total injuries of this person? But if this is a strike and a laceration, a direct blow to that area, you might want to consider a fracture of that particular bone there, or somewhere else on the of the bone. Okay. Be careful with joints. Injuries in and around joints need to be secured and stabilized above and below. Again, above and below, the joint above and below. So if you have an injury with the hip, with the knee, you guys mobilize the hip and mobilize the ankle. Padded board splints, are standard throughout the industry. Some are good, some are not. Maintain stabilization manually there. If you encounter resistance, a slight splint the limb as a deformed position. All right. No one says you have to, straighten it on out, especially on a long board. But if it is a long bone shaft fracture, this results in the deformity. Use the slight manual traction to align it and then splint it. But that, again, that's two people. You can't put an alignment and then do it by yourself. It makes it, the bone can come back together a little bit. If you have a second person, very good to have that. Rigid splints. We already talked about different splints. Non-formable splints made of firm material applied to the side, both sides. That's your padded board splints. It takes 2 EMTs. I like that. It takes 2 to do a rigid splint. And they give you a skill drill in 3.2 on skill drill. Not a figure, but a skill drill. I think that's, I don't know. I think that's on their page 1103. But those are some of the things that come about on that. Two situations you must splint a limb in the position of deformity. When the deformity is severe, okay? When you encounter resistance or extreme pain when applying a gentle traction, and most dislocations to the splint, most dislocations should be splinted as found, and that's true. The shoulder and all that, you can get in some funky positions with the SAM splint to help you splint the arm where it is. It's, if the shoulder dislocated, be up in the air, down, low, whatever, they're going to be in pain. But the idea is when we splint them, we want to put them in a position of comfort. Is there any position that they can be in that they do not have pain, or the pain is tolerable, is something they can actually withstand while being transported, or while you're transporting, you can call for an ALS intercept and you get someone there to control with the pain. So, and these are all the different types of pain. Most common form of soft splints, pre-contoured, inflatable, clear plastic, air splint. There's a vacuum splint there. It all depends on what the company actually has and what's used in that particular area. I don't see too many people using the vacuum splints because they're expensive. And I'm sorry, EMS is a business, and things cost money. We don't have a bottomless pit, and reimbursement, for some of those things just don't come around. So, do we buy a $1.50 padded board splint, or do we buy a $1,200 vacuum air splint setup? Yeah. If you're the CEO, what do you think? Air splints have some drawbacks in cold weather. So I remember Ski Patrol used to use those air splints for a while, but then they realized, hey, it's cold out here. You can blow this thing all you want, but the cold air is going to shrink it. So the original thought was the air splint would actually give buffer between it. So they really don't do it. Zippers can stick, clog, dirt, or freeze. Try to take a air splint out of a backpack or a first aid kit when it's frozen. Right. Most of you, most cover all the wounds with dry sterile dressing and then splint it as it is above and below. So I don't know if I really haven't used a zippered splint in probably 30 years. Probably initially back in my old days, but I haven't seen a zippered splint being used in 30 years. Traction splints. Again, there are all different types of traction splints. There's reasons one are better than the other. One you can use they'll actually splint both femurs. One is a little bulkier. One is real thin and good for maybe backcountry work. So you're going to have to, again, the primary premise of a traction splint is to pull the bones apart from each other and keep them apart so they do not create nerve damage, more bone fragments, bleeding, and increased pain. So that is the purpose of putting a traction splint on. Is the biggest difference between a traction splint and a regular splint is that you are physically pulling and keeping that traction so to keep the bones away. And that's why we use a mid-shaft femur fracture and not for the tibia fib fractures. We do it only for the femur and to pull them apart and keep that because of the muscles there and such large arteries. Okay, do not use traction splints. Just basically what you're using is for mid-shaft femur. All those other things that you don't. Okay. Proper alignment requires, proper application requires 2 EMTs. Okay. So you look at this, you're going to expose the area, you're going to tell the person what you're going to do. Okay. And what our position lie, This one under the amount of traction, and it varies between each particular person, but often does not exceed 15 pounds of pull. So some of the traction splints actually had a gauge on there of how much pull you did on that. Pelvic binders are very good. And for pelvic injuries, you know, things you need, some places actually still use pneumatic trousers, used called mass trousers, is a trade name. And basically, it's a pair of pants slipped over with one leg, you know, two legs, they're velcroed together, and then an abdomen. And sometimes they will inflate the abdomen or all of them, because you can't use a if you inflate the abdomen, the pelvic area, you have to inflate the extremities also. And the reason why is because you don't want to get compartment syndrome on that. So binders are very good because all it does is holds the pelvic girdle in place so it doesn't fall apart and cause a lot of pain. Pelvis fractures can create and lose a lot of blood in the cavity, and you will go unnoticed even with as much as 3 units or 4 units of blood in the pelvic cavity. It's hard to detect that. So we always think of someone who has a pelvic fracture, we need to give them oxygen and fluid and treat for shock. Okay. Hazards of implying splint, you know, compress the nerve, tissues, and blood vessels, you know, possibility. It takes time to apply all this stuff, so therefore there's a delay in transport if the person has life-threatening injuries. Reduction of distal circulations. Again, that's why we reassess to make sure we do or don't have it. Aggravation of the injured site, maybe, or injuries of tissues, nerve, blood vessels, all these things can create excessive movement. I think that's really, if you put the splint on improperly, is what you're really looking for here, is from the problems that you have. Transportation. Again, this is the first line is right off the bat. Excessive speed during transport. Here's a question for you. When do you turn the lights on and sirens in responding from the scene back to the hospital?
Situations where time is of the essence, like cardiac arrest and stuff like that, because time is muscle.
Right. So when you have a critical patient that you cannot stabilize, all right? If we can stabilize, and that's what we'd like to do, is stabilize a patient, all right? We don't necessarily need lights and sirens. And the reason why I say it is because we don't need the driving normal flow of traffic and driving lights and sirens to the hospital. A lot of times the difference, if you've been in the city, you know, and you have a hospital right, you know, right around the corner, things like that, you're really only talking maybe 3 to 4 minute difference. Okay. And do you need to jeopardize the safety of the public and you by putting on the lights and sirens to get there? Now, if the patient is stable, you can probably take the extra time. If they're not, you know, but again, excessive speed is, there's no reason to go 90 miles an hour with lights and sirens, you know, on a back road. So, though people will get anxious when it comes to a pediatric cardiac arrest or a pediatric problem or something like that, they'll get all excited and not realize they should not be doing that. They're not saving that much time. All right. So the limb can be stabilized once the dressing and splinting is applied. A patient with pulseless limbs must be given a higher priority. So, let them go. You got an hour to get to the person. So if you got an hour to get there, why, normally it's going to take me 20 minutes to get there, but if I go licensed siren, it's going to take me, 16 minutes to get there. It doesn't make a difference. Sorry. Special muscular injuries, clavicle and the collarbone is one of the most commonly fractured bones in the body. Okay. Collarbone, I don't clavicle. Fractures of the clavicle occur in children when they fall or reach their hands out. Same thing with elderly patients, they're falling. If they get their hand out, most of the time, senior citizens or elderly patients don't get their hand out in front, and so they smack their face on it, on the ground. Patient with a fractured pelvis will report pain in the shoulder. You can actually look at this drop in the person's shoulder as it goes along, or you can see it stick up, one or the other. The shoulder may drop and the bone may stick up on the. So generally the swelling of the point of tenderness will occur over the clavicle. It's because it's subcutaneous. The skin actually will tent over the fragment. So it's just underneath the skin. So therefore, once it breaks and gets displaced, it will show a little tent right there on that. And doesn't occur much less frequently. Results prior. Nah, nothing really different we already talked about. Joint between the ends. Okay, the joint between the outer. Look at it. Look at this a picture here. So we have the joint that's been interfered with in the collar. Clavicle has been broken. Very simple. Again, sling and swath are the means of doing it. But look at the sling. To show you in your class how to put a little knot in where the elbow goes, so he has a little place to put his elbow, or you to put his elbow in. But the outer side of the sling comes up over the injured side. Okay? And then you're using not only that sling to help immobilize it, but you're putting the swath around underneath it, and now you will have the body itself. So you put the arm is now stabilized by two means, the body and of the sling. Dislocation of shoulders. Okay, the joint might hang loose down there. The head of the femur, the femur head, not femur, humerus head, excuse me. Those two joints right there, when the shoulder is dislocated, the head most likely is dislodged anteriorly. So can be posterior, but a lot of times, most of the time, it's anterior. The head comes forward and down versus posterior, and a lot of that is because of the scapula. Fracture the humerus. Okay, basically mid-shaft distal. You're going to do any other fracture. What do you want to do? You want to first keep it still. Second, you want to see if there's any distal pulse or neurological deficits distal to the injury, and then we're going to splint it. Okay. Fractures of the humerus result from falls and common in older people, yada yada. On that, midshaft often in young patients usually a result of a violent injury. So if you go to the city and you decide to see some of the violence that actually occurs, it might be an attack, a basketball court or something like that. So the severely angulated fracture, you should consider applying traction to realign it. But again, we caution that in regards to excessive pain, resistance, and things like that. This is definitely, again, two-person. One, even after you pull traction on it, and straighten it on out. That needs to be held while the person puts the traction, not the traction, but the regular splint on. You're not putting traction splints on the upper body. So gently pull in line with the axis of the limb, and yeah, what the hell am I? We'll go back here. Yeah, splint the arm and sling a swath. There you go. Okay, where you guys go? Where did you go? Elbow injuries or the dislocation. You don't know if it's fractured or dislocated, less than the bones are sticking out. I would say in this particular case, you want to splint as you see it. Fracture segments rotate, significantly produce deformity and cause injuries to the nearby vessels. The more you move this, right, this is going to be an unusual situation of how you're going to get the person in the ambulance with it. It's sticking out like that. But again, it's a joint, and therefore you do not straighten out the joint. Dislocation of elbow, athletes is usually where it happens, not really older people. The ulna and radius are most often displaced posteriorly and relatively humerus. So as much as we're looking at posterior anteriorly, it's dislocated. If you want to be able to tell a doctor that I got an anterior dislocation, not going to make any difference to him, but it's a nicer picture because once he gets there, he's going to see it and make a decision one way or the other on how he's going to reduce that. Strains. It can be misdiagnosed, but guess what? How are we going to treat a sprain? Same as a fracture. So the diagnosis is often mistaken and applied to the non-displaced fracture. So fractures of the elbow process of the ulna. So this fracture can result in some direct and indirect forces, usually associated with lacerations on that. Patient is an active person. Patient will be unable to extend the arm. So this is an assessment here in regards to the elbow injury. They're not going to be able to move it on their own. Again, you're going to assess the distal sensation and pulse and quality of it, see it's weak or strong compared to the other, and you're going to sprint it as it lays. Fractures of the radial head often missed during diagnosis. Well, not us, because we're not diagnosing it. The fracture generally occurs as a result of a fall, outstretched arm, coming out of a tree, or off a ladder, or a direct blow to the lateral aspect of the elbow. Attempts of the elbow, rotating the elbow or wrist, cause discomfort. Now, I believe that. So again, this might be someone who fallen out of a tree, a kid fall out of a tree. We're not diagnosed whether it's fractured or not, but we're going to treat that as a fracture. Potentially serious, requiring careful management. Again, it's a limb, so we do like to keep our fingers, always assess distal neurovascular functions periodically. So we did the before and after, but if we have a long commute, 30-minute, 40-minute commute to the hospital, we want to make sure we reassess it and say, hey, I had it before, but now I don't have it. So it's an update to call to the doctor and to the hospital saying, hey, we had good circulation, but now we've lost that. So that's a higher priority for them. They're not going to put them in surgical daycare, or they're going to put in the waiting room, they're going to actually bring them into a actual room to be assessed. Fractures of the forearm, shaft, radius are common in all age groups. Yeah. Seen mostly in children, as said, in elderly people, only because the kids are more active, and elderly have bad bones in regards to that. So they usually break both bones there at the same time. Isolated fractures of the shaft of the ulna may occur, but that would be a direct blow to it. Stabilize the fracture. You can see the padded board splint, air vacuum, pillow splint. Injuries to the wrist and hand. I kind of really, it talks all about these different types of injuries, how they're located, and that. On this type of injury, a wrist and the hand, I like to use a SAM splint. And the reason why is I can get it to measure it on up for the proper length. I can curl up the end so it's in the shape of a 16-ounce can of soda, and lie the hand over on top of that, bring it up underneath and secure it. It allows me to feel the fingertips to make sure that it's still getting circulation. So I get capillary refill. I can see how warm or cold they are. And yet I have it in a anatomical position that's normal and should be not causing any pain to the patient. So that's what's is what you really should do for that type of fracture. Fracture the pelvis. When we assess the pelvis, it can be life-threatening, but as we've gone down, and how you assess the pelvis is that as you're coming down, you put both hands on the ischium. Okay, that's the bony process up front there, and you gently push out, and then you gently push in, compress it. And if you elicit pain on either one of those two motions, you presume that the pelvis is fractured. Because it's vascular and because it can lose so much blood without you even knowing it, you splint it with a pelvic binder. And even if you pass your patient off to a paramedic or someone higher, I, as a paramedic, would not squeeze and reassess it. I'm taking your assessment and taking it as truth and treating it as a fracture, because if someone keeps on pushing, not only the pain, but we can cause more bleeding that I can't stop because it's internal. You should expect the fracture of the pelvis if the patient has sustained high velocity. We're talking about a car accident possibility there, falling off a building. Deformity swelling is not really normally going to be seen. Most signs of a fracture of the pelvis is simply tenderness or instability. The instability on the firm compression and palpation of that area. Assessment for tenderness as follows the steps. But again, each iliac crest that we push out on is important for us to think of that. So here we go in a diagram showing exactly the pelvic region for tenderness. This is how you're checking for instability. Right. Dislocation of the hip. The hip is very stable ball and socket joint. Only a significant injury do we get a dislocation. Right. Most dislocations of the hip are posterior. Remember, we were talking about the shoulder being anterior, most common, but posterior. And in regards, they're looking here at the motor vehicle crash, which the knee has met the direct force. The entire femur is driven past right back. So Mechanism of injury, we're looking here as a simple motor vehicle crash. There is maybe not any real facial injuries, but we're thinking of maybe a possible C-spine assessment to put the person on a collar. And I wouldn't, and then you start going down the person. I'm fine, but I hurt a little bit in my leg. So you want to assess this a little further. Knowing the mechanism of injury now allows you to assess that area better to see you come up and identify, yes, there is a dislocation, or it may be a fracture, but we're going to treat it the same. Okay? And you suspect a hip dislocation in any patient who has been in a motor vehicle crash that has a contusion or laceration or obvious other fractures. The entire femur now has had, what has happened is it just drove the femur back in a straight line. Okay, so what other injuries are we going to have with that? We got the indirect injury from the femur head popping out back of the pelvis, but we also have the initial phase of the knee hitting the dashboard, and that's what drove it back. So we have two injured sites that we need to assess just based on the mechanism of injury. Yeah, we already know about that. So you get sciatic nerve problems, distinctive signs, severe pain in the hip, yeah, strong resistance to movement of the joint, and tenderness on palpation. So the sciatic nerve is a very large nerve, and it hurts like heck for people. People who have dislocations or just pinched nerves. It is extremely painful with that, knowing someone like myself who has had actually some nerve problems like that. So when the head of the femur is forced out of the hip socket, it may compress or stress that sciatic nerve, right, and lead to a partial or even complete paralysis of that leg. I'd rather have temporary paralysis with no nerve, with no feeling, than having it give me all these excruciating pain on that. Do not attempt to reduce the dislocated hip. Plain and simple. You basically want to support it, maybe with pillows, maybe with a hip immobilizer, stabilize it, transport, and go to the hospital with them to do the x-ray and take care of it from there. Of course, they're also going to give some pain medication. Fractures of the proximal femur. Again, ain't talking about the femur. It's very vascular. A lot of things going on there. You're going to have possibility of a lot of bleeding. If it breaks through the skin, now we have an open fracture. We're not going to put a traction splint on that because we're not pulling the bones back into the body. So breaks going, of the neck and the femur, and all that particular area, it all depends on what they're going to do later on in fixing the femur. So patient displays some deformity. They lie with the leg externally rotated. Okay. So what do we say here? We got a fractured femur, and the leg is rotated externally. If the leg is rotated internally, laterally, medially, towards the middle of the body, it's a hip. Rotated externally, it's a femur. Right? And what else is a classic sign of a fractured femur is, besides the rotation, as you look at the other leg, it's going to be shorter than the other. Because the muscles, such strong muscle, will pull the leg close. That has soft tissue, age, severity, injuries, distal. Make sure you put your traction splint on. Make sure you do your before and after assessments of neurovascular assessment on that. Give them high flow oxygen, treat for shock. Even if they're not in shock yet, let's prevent it. Why do we have to wait, until they go into shock and then say, oh shit, we got to get some fluids in, we got to get some pain medications, and now, we're putting ourselves behind the eight ball. Treat for shock early. What do we talk about? Patients, trauma patients come in the emergency room, they're cold. Did you maintain body temperature? Did you put an aluminum blanket over them, around them, to maintain their temperature? People can get hypothermic in the summertime too. Take a temperature. It's part of your vital signs. Okay. Region. This is all talking about, how all this stuff about fractures of femurs, this portion, that portion. It's great to know that. You can read up and understand that, but it really, when it comes down to, you got to treat the pain, you got to treat for shock, you got to find out, determine whether or not you need to put traction splint on it or just splint it as it is. And some of the things you're going to note, in your report, that you splinted as is, you had good CSMs beforehand, CSMs afterwards, and transport. If they're in a lot of pain, call for ALS, let them come on in and give the patient some pain medication, because they really would appreciate that. We already talked about moving in. We talked about nerve functions and muscles and what they do. We already know that. Knee injuries to knee and ligaments. All right, treat it as a fracture. It's a knee, so you do not straighten it out. You're going to splint it as you see it. Okay. You're not going to do anything different for a dislocated patella. You're not going to do anything for a fractured patella. You're not going to do anything different for a ligament area. Splint it as is to keep it from hurting more, and put ice on it. And if it's really a lot of pain, call for ALS for pain control. So especially suspect ligament injuries which occur when abnormal bending or twisting forces applied to the joint. So that's part of the MOI. When you examine the patient, you will generally find the swelling, ecchymosis, point tenderness, joint diffusion. You should splint all suspected knee ligament injuries. I think I just said that. Come on. Dislocations again. Dislocation of the knee are true emergencies that threaten the limb. Well, it does and it doesn't. As much as they want to say that it's a true emergency, I'm not going to go lights and sirens unless there is a lack of neurovascular assessment post to that. Okay? We have time to drive to the hospital without trying to kill ourselves. Okay? When the knee is dislocated, the ligaments that provide support may be damaged or torn. You know what? They get to the hospital, you tore the ligaments in your knee. Yeah, we'll do surgery next week on it. And yet we blew through the red lights and sirens, and we almost got ourselves, or we got someone else injured because they veered away, didn't hit our ambulance, but they hit another car. Patient will typically complain of pain in the knee, report the knee gave out. Okay. Okay. And so we all talk about the different complications you can see listed there. Inadequate pulse, or if adequate pulses are present, splint the knee as that's where you go. Fracture the knees. Same thing. We already talked about that. Adequate pulse. Again, assessing before and after you splint. Know what you have. Dislocation of patella. It's just another bone in the knee. We're not gonna move it. We're not going to try a realignment. All right. Splint it as found. Again, reassess before and after. Apply ice for the pain. Note what the pain level was beforehand. Note what is pain level after your care. Your care was splinting as is, placing the ice on it, and the pain has gone from an 8/10 to now when you get to the hospital, it's 5/10. That proves that your treatment helped and improved the patient's care. Bingo. That's what you do. Single fractures may occur as a result of deformity or significant angulations or rotations, but most of you are going to get fractures of both, not just one. Ankle injuries. What do we talk about ankle injuries? We're going to apply ice. You know, it was, you know, the RICE method. Okay, everyone knows the acronym RICE: rest, ice, compression, and elevation. Okay, very simple, easy to remember, very simple, and it's being done by EMTs and non-EMTs, you know, or even paramedics. You know, I have the option of giving them some pain medication, but in reality, that's all you really need for this, and it's going to take a while for it to swell and go down, and for them to actually walk and on this ankle. But they'll take an X-ray at the hospital, see if anything's broken. I don't think there's anything new right there. Yep. Again, it says apply gentle longitude traction to the heel. If there's a gross, I kind of disagree with that. If they would want to do that, but there are so many other bones in that area of the ankle that trying to fix and pull it into alignment with just that one bone. I don't think it's done. I've never done it, never thought about doing it really. And it says release the traction and apply the splint. So what you're doing is they want you to pull it, try to get in alignment, and then let go of it, and then splint it. Foot injuries. All right. There are so many different types of foot injuries that are out there. I mean, we talk about how they're done. Mechanism injuries is probably one of the biggest things to think about again. How did they land? How did they get hit? Think about, you know, the initial on the primary force, direct hit, and the secondary after that, what got hit after that. And basically what it comes on down to good foot injuries is you know, a pillow or some other, you know, blankets wrapped or tied up and wrapped around it to stabilize it and keep it nice and firm, and applied ice to it. If you suspect a foot to be dislocated, immediately assess for pulses. We're going to do that anyway. All right? And it's important just to know that again. If there are no pulse, you want to call med control to advise them that bumps you on up to a higher severity of when they're bringing in, or for them saying, hey, I got to call in an orthopedic guy to take a more severe look at this, or maybe we make arrangements already to start shipping the person out. So we talked a little bit about that. So breast, ice, compression, elevation, and they put in splinting now. So it's RICE, multiple RICEs. So. Amputations, control the bleeding, treat for shock. Surgeons today can occasionally reattach, depending upon how big it is and what it is, and where it is. All these different things can control. Don't promise the person that they can put it back. The doctor can put this finger back on. They say, let's get in there and let's reassess it. I don't know for sure what they can do. Make sure you immobilize the part that's bulk, especially if it's not totally detached. So again, do not sever any partial amputation. Control the bleeding. If the bleeding is severe, put a tourniquet on that. Make sure you wrap the part if it's complete amputation. Wrap it, dress it, put it in a plastic bag, and then preserve it as best you can. Use some local protocols, but basically we're using. I think water and some ice is the best thing, and as long as you keep it in Ziploc bags, that's fine. I'm sure everyone carries in their first aid kit a small Ziploc bag to put the body part in, and a large Ziploc bag to put the ice and water in, right? Not. Make sure you transport the part of the body with you and not leave it behind. I did have a motor vehicle crash that my department was involved with, and they did the extrication, but they still took another 5 minutes of extricating to get that limb out before they so the body went, the patient with one ambulance, and the amputated leg went separately. So most common fractures, the tibia fibia, yet in children, compartment syndrome. So compartment syndrome is what? It's basically what we're looking at is a lack of blood flow to an area where the pressure has built up, and it prevents the blood from going back. Okay. Again, it's not something we're going to necessarily deal with on the field, because you can see there, they say 6 to 12 hours after injury, and that's something that they're going to deal with in the hospital. But as long as we get them in a reasonable amount of time, we're fine, as long as they're not in what they call extended care, like out in the woods. If you're going to become a wilderness EMT and start taking this stuff out in the woods, that's where you get a long term, and you have to worry about some of that compartment syndrome. But excessive bleeding, severe crushing injuries are what we're really looking for here, and that's where they'll actually cut the skin and reduce the internal pressure so it doesn't do damage. Kind of pain, proportional to it, passive stretching the muscles within the compartment, all that stuff, as you clearly see there. Again, you're not going to necessarily see that. We might feel some type of that if the person has been trapped and the extremity has actually been cut off from blood supply for a time while we're doing extrication. Then at that time is when we're going to start thinking about that. You've got to have ALS on that. And then when we do bring that person back, we might put a tourniquet on and slowly release it, because during the extrication portion, we're going to probably give them not normal saline, but lactated ringers, and we're going to give them sodium bicarb. And during the process to try, so once this release of toxins in the body, it doesn't come back and put the person in cardiac arrest and die, or put a blood clot in and die. So I don't think you're going to be an EMT all by yourself with an entrapment like that. You should have time at least to get a paramedic there, unless you're in a community where you don't have paramedics, which is New Hampshire. Pediatric patient, fracture below the elbow, knee, can look for signs, look for all this stuff. But you're not going to do very much anything different on that. Splint the limb. Immediate transport. So let's review. And so if you could unmute yourself here a little bit to get ready to answer some of these questions, we're going to bang out some of these questions. Skeletal muscles will refer to what? What type of muscles are they? A, B, C, B? Look at that. I got it right. And the reasons why smooth muscles are more of the organs. All right. If you respond to a soccer game, 16-year-old male with severe ankle pain, when you deliver him to the hospital, the physician tells you that suspects a sprain. This means what? So what's a sprain of those options that you give? Never mind saying, hey, doc, I splinted it as if it was a fracture, and you got the x-rays, not me. Anyone want to take a guess? How about C? Sounds good to me. Let's look at that.
Yep.
It's just the and tears the ligaments with partial or temporary dislocation. Okay. Yep. Okay. A young male has a muscular skeletal injury and is unresponsive. So you're not really going to get much information from this person. So you have to find the other MOI. You will not be able to assess what?
D.
Correct.
A.
No.
D.
It's going to be D. It's going to be D, the sensory and motor function, because you're going to ask him to feel this or move that. And since he's unconscious, he can't do that. The capillary reachability, you're squeezing, the distal pulsar, you'll be able to, any false motion, you'll be able to identify. So. Purpose of reducing splinting in a fracture is? B. All right. Purpose of splinting in a fracture is to prevent the motion and body injuries and fragments. 5. Motorcycle crash. All right. Bilateral mid fracture femurs. Patient's conscious, restless. Your skin is cool and clammy. Pulse is high. What's the
C.
most? What is the most important splinting? What is that?
C.
Very good. C. Right. Securing the lower. We don't have the time to put individual traction splints on that person. Let's get them on board, and they're already in shock, and we got that. Let's go. This is a load and go. Treat while en route. Very good. Effective immobilization of a fractured clavicle. You should do what?
A.
Gotcha. Very good. 7. Patient tripped and fell, landed on her elbow. She's in severe pain and has obvious deformity of the elbow. You should do what?
Well, you're obviously going to assess the distal pulses anyways.
Yeah, you're going to do that anyway. And I basically, it's going to be B, manually stabilize the injury. But you're
Yeah, 'cause
right.
you have to stabilize for treatment, for transport.
Yeah, you got it. You understand that. Come on, let's go. When treating open fracture extremity, you should do what?
B.
Correct. Dress it before you do it. So if it goes, you don't got to do it afterwards. Which of the following are the greatest risks for shock due to blood loss?
Pelvic.
Which?
A.
Very good. Okay. Injuries here. Number 10. Injury to her knee while riding a bicycle. She lies on the ground. Her leg is flexed. Distal pulsar pregnant. What is the most appropriate treatment for her injuries?
B.
B.
B. Very good. Yeah. All right. Take another 10-minute break. What time? How long you guys? That took too long. That took 2.5. That took 2.5 hours. I got to speed it up a little bit. Take a 10-minute break or whatever. Get up, do things. What time and how long do you take a lunch break?
Typically, I think we do an hour. But we just have one more chapter to do, Dave?
Oh
Or is
no,
there 2 more?
we got 3.
Oh, 3 more to go?
Yeah.
Okay.
We got.
All right.
Yeah. I'll try to get you out of here by 2 o'clock, but I'll have to go a lot faster.
Yeah. Okay.
That's
It typically gives us like an hour off at noon, I think. Is that right? everybody? I believe that's what we've done in the past. I don't necessarily need that much time personally, but
I just need enough time to feed the kid.
This conference will now be recorded.
Hi, do I have people here?
Right. I'm here.
Good. Glad someone is.
I'm here.
Yeah, I'm just frustrated with this computer and getting the presenter's view here for some reason. It just does not want to help out or not, but we'll see. What do you see now on the screen? Anything?
we see the slides with them on the left-hand side, and the slide that you're looking at in the center. It's like just not in presenter mode, but we can still see the slide.
Okay.
So if you wanted to go through that way, it'd be fine.
What are you seeing right now? You seeing both the medicine and gynecological, or just see the medicine?
It says, it's the slide that says, it has the pictures of the firemen, and it says chapter 23, gynecological emergencies lecture.
Now you're okay. It's not showing that up. So let's go here. 'Cause I already got in the presenter mode. What's it? People can see your app. Good. Why can't I do that? I don't want to end the meeting. Why can't I do that? Seeing any different screens now? You're seeing both screens now.
Correct. Yep.
Okay, so you see the one on the left, you see the one on the right, correct? And you're seeing my notes.
Yes.
Okay. Well, we'll hop along here. We'll get that other stuff done later on. All right. Take a sip of drink. I don't know why they don't provide alcoholic beverages for classes. Okay. Recognize gynecological emergency, shock associated with vaginal bleeding. Vaginal bleeding is sexual assault, infections, all these things come about. You gotta know why, who, what's going on. Women uniquely designed, they are. Women are unbelievable piece of Mother Nature. They really are. We talk here, female reproduction system, including internal, external structures. And so what we're looking there is your external structures are all listed there: vaginal, labia, clitoris, perineum area, all those things. And clitoris is the anterior end of the labia, and the anus is the posterior end. So come on, change. There we go. External view of the female genitalia. Easy enough to look at that in the book. Internal structures, ovaries, primary female reproductions. Ovary only produces, the two ovaries produce one egg every other month. So one does it 1 month, one does it the other month. The fetus develops fertilized eggs. Normally when it fertilizes, it does in the fallopian tubes. If it stays there, that's not good. This chapter here will go on over a lot of the female anatomy and what's going on inside their bodies. And this is for information to let you know what's going on inside the body, not really for anything that you're going to actually physically do or change. So, uterus is a very muscular organism where the fetus grows. So the fetus actually gets impregnated and fertilized. The egg gets fertilizers in the fallopian tubes, and then comes on down and gets planted into the uterus wall for future growth. Narrowest part of the uterus is the cervix, which is the extra opening of the vagina. Figures here showing 23 index. Keep going. Okay, ovulation and menstrual begins in puberty. So we're talking anywhere like 11 to 16. So believe it or not, when we talk about people who may or may not be pregnant due to our abdominal injuries or pain, if they just called for abdominal injuries, again, start thinking about 11-year-old, 12-year-old, you got to ask that question of whether or not they're sexually active. And don't do that in front of a parent unless you want to get hit. Women continuation menstruation into their 50s. Each ovary, yeah, I already talked about that. If fertilization does not occur in 14 days, the lining of the uterus will slough off, and that the menstruation occurs. The menstrual flow consists of blood and the separates of the lining, and it usually lasts 5 to 7 days. Women hormones during this time are more than normal, and therefore they have emotional events that most of them control, and that's not an issue. The cause of gynecological emergencies vary from ranges from sexually transmitted diseases to trauma. So recognize and properly manage patients. All right. Pelvic inflammatory disease. I heard more of that probably back when people were just using or started to use tampons, but tampons are really have matured in their quality and design, and people realize you can't leave a tampon in for the entire 5 to 7 days. This occurs exclusively in sexually active people. So you're going to, in this particular, what are you treating for? You're treating for inflammation or shock is what you're going to be looking for here. General lower abdominal pain. STDs can lead to more serious conditions, and this is usually handled in a patient's primary care physician's office or in a standalone clinic. There can be some long-term problems with this, but usually treated with antibiotics, it'll go away. This is not something you're going to investigate at all. Bacteria, most common vaginal infections affect women at 15 years or older. So we're looking here. Give me that out of my way. Let's go like this. Okay, there we go. 15 to 45, normal bacteria in the vagina is replaced by an overgrowth of other bacteria. So symptoms include itching, burning, pain, foul odor, fishy odor. So dealing with personal hygiene helps keep that area clean. And then some people, even though they do everything right, they might get a yeast infection, which can go along with urinary tract infection. Urinary tract infections are not only common to females, but also males, especially as they get older in age. gonorrhea. This stuff here is bacteria that grows in the mouth, the throat, the eyes, anus. Symptoms severe in men, more in men than in women. Okay. Again, painful urination is what you're really looking for here. All right, abnormal possible causes here: abnormal menstruation, vaginal trauma, ectopic pregnancy, spontaneous abortions, and cervical polyps, all causing possible bleeds in here. The problem that we want to look and don't want to overlook is that a lot of the stuff is normal, abnormal. Nothing dealing with a patient, no necessarily their fault whatsoever. But these are just conditions that come on up, and a lot of these, when we ask for questions, can be embarrassing when we start asking questions. So professionalism and discretion are high on our topics and how we care for things. Accurate details, and assessment is critical. You have to, your primary care here is to gain confidence and professional with your patient. So they'll give you information of the mode of injury or what's going on, the current past medical history, pertinent past medical history of all this stuff. So anyone who neglects the kind of possible causes of childbearing will eventually have a problem down the road. Thank you. Size up, scene size up, same as anything else. Nothing really, going on here. You have to observe and take note. Nature of the illness. The clean environment. Are they in a hotel room where they're living, or are they living in a mansion? It doesn't make any difference, but you just need to make sure the scene is safe for you. If you think the scene is unsafe, back out until you get police help or some other. No one wants you to endanger yourself. Okay. Mechanism, mode of injury. In some patients, the problem may be given by dispatch, sexual assault, bingo. But other things are not that easy to determine. Again, primary assessment, stable or unstable. Get to play or play while en route to the hospital. And those are things. Circulation, skin, Gynecological murders are not life-threatening normally, but can be, especially post-delivery. But it can be, depending on how much they're bleeding, it can be. And you can't really stop that unless you get in for surgery. Investigate the chief complaint. Some questions may be extremely personal in nature, sensitive. They want to protect their dignity. Girls don't really want to talk about their adolescent sexual history. And maybe you can do it in private. So you look here, abdominal pain. Again, onset, go through all the questions, your sample and your OPQRST to get all that information. Sample, we all know that. They say, no, we're not on any medication. Are you on birth control? Do they are oral birth control, or are they have a implant? Yeah, sorry. History, finally include, pertinent secondary assessment. And we did our second assessment and then we found out there are things that we have to look for or concerned about. So instead of doing another head to toe, check your eyes, pupils and all that stuff, then we're doing a pertinent for that particular area of the body. Physical examination, limited, protect the woman's privacy. And if you did all this, or say you didn't, what are you actually going to do? I mean, if there's an emotional aspect of it, we're already going to give emotional support. We're already planning on trying to swap out a male to female, but how much does it really need to go down to the private area and look at something? You already know what to do, and you don't need that past that. Visualize the bleeding, ask about quality and quantity. All right. So if she's standing there or sitting there on the bed or the toilet, especially in the toilet, you already know how much is in the toilet seat, in the bowl. Hopefully she did not do it, but you ask the questions I said earlier. External pads to control the bleeding. Hypoperfusion, so keep shock in mind. Pain associated with the bleeding, that's important. Maybe you can get ALS to assist in controlling the meds on that for the bleed, for the pain, to manage that. So, is there any discharge? That's a good one. What's coming out is important. The color, the smell, odor, things like that. So it's important to observe, ask some questions, but observe with your eyes, nose, all your senses. These vital signs, basically what you're doing is you're looking for changes. Right? And if they're pregnant, of course, they're going to be something that's going to be elevated. You expect an elevated heart rate. You expected blood pressure be maybe a little bit lower. Quantity, the respiration is going to be increased. Okay, rhythm should be the same. Quality should be the same. Later on, she's going to be maybe a little has to breathe faster because of the movement of the uterus displacing and rising up against the diaphragm. Modern equipment, again, all your stuff you use for your normal vital signs. Initially do a manual blood pressure, then you may go. Now, when you transport these people, you're going to be lying on their side, so make sure you try to take it, because it'll be a different blood pressure if that person is lying on their left side and you take a blood pressure on that arm beforehand. Now they're laying down, and now that you've changed it to below the level of the heart versus the other one's above the level of the heart. So stay with one arm that you're doing the blood pressure on. Repeat. Chief complaint. Identify, treat changes. All this stuff is all normal stuff here. Communication documentation. Pertinent information by your rater report. Again, chief complaint, vital signs, ETA, maybe what you've done or haven't done, and any improvement. Maintain airway, privacy, patient privacy in the public areas. Move to the ambulance, like I said before. Determine the cause of bleeding is of less importance than treating the patient in shock. Again, I've asked that. How many sanitary napkins or how many tampons you go through? What's normal for you? 2 a day is normal, and now you're going through 6 an hour. Big difference. Treat external laceration abrasions just as you would any other. Control the bleeding with put in a dry sterile dressing on it, and This says use a diaper. You could, if you don't have it, just put the bandage. I mean the dressing in the vagina area if that's where they're bleeding, and put the person's panties back on. Assess management for special conditions. PID. Again, your complaint here is abdominal pain, and it can be anything. And we are associating abdominal pain to be that in nature for a female of doing something with her female internal organs, unless proven otherwise. Your pre-hospital treatment is very limited. Absolutely. And there, at the bottom of the screen there, non-emergency transport is recommended. I mean, unless they're bleeding out, there's no reason to scream and yell with your sirens and lights. Sexual assault and rape are common. All right. 1 in 5 females, 1 in 4 women sexually molested. All right. Often before the age of 12. So as we're thinking about, we're assessing a child that may have been sexually assaulted. Right? We have to think of the emotional aspect of this patient. It's just as much and sometimes more important than the physical damage that may have been done to the person. Right? They're all things, if you suspect a sexual assault, if you weren't already called to it, you should call for police involvement if they're not already there. Okay? So you need to get the police online, preserve evidence. Paper bag versus plastic bag. Do not cut. Do not have the person brush their teeth, take a drink of water, go to the bathroom, discard the clothing, no showers, all that stuff is important for a future prosecution. Now, here, drugs might be involved in this. So there are a variety of drugs that are on the street that people try to use to control or manipulate females into sexual activities. Let's see if they list one here. Yeah. No. So asking the person to repeat details may shut the victim down. So it's not necessarily looking for the details, but were you sexually assaulted? Are you all right? Do you hurt anywhere? Yada, yada. Not, oh, let's take your clothes off and let me do an examination. That's a far cry. Your focus should be on provide medical treatment to the patient. And I'm going to say here, medical treatment is part of the offer psychological. That is medical treatment as far as I'm concerned. The psychological aspect of someone being raped or psychological of them, by bipolar is still patient care. Preserve evidence. Don't let it get thrown away. Don't let anything get shoved down a toilet. Take history and do some care. Here's a little table. You can look at that later. Review. What's the narrowest portion of the uterus? Anyone? Great.
Cervix. B.
Okay. Thanks. I guess some people. What is the outermost cavity of a woman's reproductive system?
Vagina.
Yeah.
Shit, you heard me?
Yes, I did.
I was trying to be quiet so others could answer.
Well, maybe they're shy. If fertilization has not occurred within blank number of days of ovulation, the liner of the uterus begins to separate and menstruation occurs. Come on, guys. Girls know this. Come on. I think I lost all the guys. Try 14 days, guys, if you're listening. The onset of menstruation is called what?
Menarche.
We did not
B.
go over this in my lecture, but it was in the book. Okay.
Menarche.
B.
Oh, B, very good. Gold star for you. Which of the following can cause vaginal bleeding?
D.
Everything.
Yeah, all above. What is the most common presenting sign of PID?
Pain.
C, lower abdominal. 7, obtain the sample history. Which of the following pieces of information is important to obtain? Yeah, we think all of it would be, but look at that. D, all of them. Good. 7, 6, 8. What is the EMT's first priority when dealing with a patient experiencing excessive vaginal bleeding?
D.
B.
You know, I agree with you. Which of the following drugs is commonly used to facilitate sexual assault?
Rehypnol.
Roofies.
A.
Yeah. That was quick. Quick. You should discourage a rape.
Everything. All of the above.
Gotcha. All of the above. All right. That's all done with this one. So now all I got to do is get us to number 3 for our show. So I'm going to go back and see if I can get number 3 up and running here. So I'm going to stop the cameras and my noise here, and we'll go for me getting this ready. Stop recording.
This conference will now be recorded.
Okay, so now we're under special patient population here, and we're dealing with chapter 33, obstetrics. Females are very special. But the neonatal care is very difficult, very precise, fast work, and things we have to be concerned with. Applying this, you have to have some fundamental knowledge and development of children and how we're going to transport them. When you get to their job, volunteering or paid, and you need to know how you're going to transport an infant and child, and the policies that you're having versus mom and child, or father and child go into the same vehicle. Sometimes injuries don't allow you to do that. And how is that child transported? And there's a nice little the Fire Academy under response online program. There's a nice little videotape in regard show on that, and you get continuing credits for that after you get certified, nationally certified. Update, recognize management, normal delivery, vaginal delivery in pregnant patients, anatomy and physiology of normal pregnancies, and physiology and complications of pregnancies. You know, most pregnancies go smooth. They do not have problems. So if you do get your situation where you're going to be delivering a child, it's a little bit more than she's doing all the work and you've got a catcher's glove. But there's things that you have to do to make sure that it's a safe one. But normally, you're going to have a smooth delivery. Here they talk about what you're going to do is the standards of how you manage a normal delivery and abnormal delivery and the different types of them. Treatment, third semester bleeding, we talk about here, ablupia and placenta previa. So all these things you got to realize on your national registry exam, or maybe even Kevin's, be able to know the difference between those two terms. Spontaneous abortions or miscarriages, ectopic pregnancies, and preeclampsia. National standards state here, newborn care and neonatal resuscitation. Neonatal is referring to from the time of birth to 1 month. That's neonatal. After 1 month, that's considered newborn. Trauma. Fundamental knowledge, and you should have the basic emergency care, transportation, and of acute injured ill. Most kids, it's going to be respiratory. Respiratory is going to be the #1 problem that you're going to have for them. Special consideration, recognizing and management trauma in the pregnant patient, the pediatric, and geriatric. How do you like that? We've gone from newborns to geriatric. Each one of those age groups actually have separate programs that later on, if you want to take, actually do that. So there's a geriatric program called GEMS, dealing with geriatric patients. Pediatric, there's a pediatric program, and the pregnant women, well, there's lectures and simple programs to deal with that, but there's not a separate certification on that. So no stuff about your pregnant, assessing a pregnant and pediatric patient. Most diversities occur in a hospital, or most deliveries occur in a hospital. That's true. And it all depends on whether it's the woman's first or second or third or fourth delivery, on how fast it usually goes. So most of them expect to get to the hospital at least on their first. If you must, you make the decision to do it in the field and you're going to assist in the delivery, you need to make sure that you know where you are. So later on in the birth certificate and all that stuff, you can where the baby was born. The baby was not born at the hospital in Boston. The baby was born in the roads of Dorchester, or vice versa. So female reproductive system. All right. We have the ovaries, fallopian tubes. All the 1 through 4 are all internal. The cervix is actually the beginning of the end of the vagina, but and the breasts are all external. Hopefully. Ovaries, 2 glands. We've already gone through that. And every ovary contains thousands of fallopians, and each fallopian contains an egg. During menstrual period, there will be one of the fallopians successfully all maturing and release an egg. So they'll leave 1 egg. They're all mature, but one will release 1 egg at a time. The ovary approximately 2 weeks prior to the menstruation. If fertilized, and again, I said earlier that it gets fertilized, it is in the fallopian tube, and it needs to travel down. So if the egg is not fertilized from 36 to 48 hours after being displaced or get out of the way. Out of the way. Sorry. There we go. Okay. Again, it hasn't been. It will be released. It will die, and it will slough off. And we already talked about this being, 28 days. Some people say 30, but it's a 28-day cycle on that. And you saw the anatomy of where the tubes extend and they start and where they extend to. Fertilization, sperm meets the egg. We have birth starting to develop here. So the fertilization inside the tube, then it follows down to the uterus where it's implanted. And at that point, the fetus can start to grow and over time become a viable and healthy child. The uterus, if you didn't know, is a very muscular but highly vascular structure. Carries a lot of blood around there. So any type of bleeding in this area can be massive and fatal for the mother, or the female, I should say. So it will contract and push the baby on out. Birth canal is made up of the vagina and a lower third of the cervix. And then during the pregnancy, the cervix, and what we talk about when we are assessing, we're assessing our pregnant woman who's having abdominal pains regularly, and we're thinking that this is a beginning of the first stage of delivery. And one of the things we want to know is if the mucus plug has been broken, the seal has been broken, or if later on if it doesn't break, the water is broken. So this is all in the second phase of delivery, or labor, I should say. Come on. Here is your anatomy of the abdomen with the structure of the female cervix, rectum, vagina, pubic symphysis, the bladder. And you can see where the bladder is in the course of the baby. It's a lot of pressure put on there. That's why pregnant females have to go to the bathroom a lot to relieve it. They get the urge to urinate, and they don't have a large bladder anymore because it's been pushed aside by the fetus. And then urine and placenta and the font. The vagina is the outermost cavity of the female reproductive system. Begins with the cervix and ends with the external genitalia. I think everyone pretty knows. Pregnant women develop breast milk, breasts enlarge, and placenta is a disc-shaped structure attached to the uterus or uterine wall, and it provides a lot of nourishment to the fetus. It is connected to the fetus through the umbilical cord, and that we're going to find out more about that. Talk a little bit more about that when we come to the end of the delivery phase 3. Anything ingested in the woman, it also gets passed on to the fetus. So that's why they tell them no smoke, pot toxins, and medications, and carbon, all that stuff is important because the baby's getting exposed to that. So if we had a carbon monoxide alarm go off and there's a female there, they're mostly going to want to be checked out by the emergency room or by your kind of GYN physician. After delivery of the placenta, separate from the uterus, after delivery, the placenta separates from the uterus and is delivered. The umbilical cord is the lifeline of the fetus connecting the woman to the head. The umbilical vein carrying oxygenated. Again, this vein is reversed than the rest of the body and up for the ones going to the lungs. These veins carry oxygenated blood from the placenta to the heart of the fetus, and vice versa for the deoxygenated blood for the arteries. The fetus is inside this fluid sac, bag-like membrane, amniotic sac, fluid sac holds between 500 and 1,000 mLs of fluid, which helps insulate and protect the baby as he floats around. The amniotic fluid is released in a gush. All right, but we know most of the time it's not just a little dribble of a leak; it's a gush when it ruptures. Right? But believe it or not, sometimes there are pregnancies where it is not ruptured until it comes out, and they actually have to break the liner with a pair of tweezers, cut the liner of the sac, and the fluid will come on out just as the baby is coming out. During pregnancy, normal change occurs in the body that are not all directly related to reproductive. Primary symptoms of these changes are respiratory, cardiovascular, and neuromuscular skeleton. Oh, I think we hit some of these things. These hormones that the woman has are increased all over the place on it, and it puts the pregnant woman at risk for complications with these things, from trauma, bleeding, and sometimes medical conditions. The fetus develops and grows inside the uterus and attaches as it stretches and accommodates. The uterus stretches and accommodates this full-term fetus. So there's a lot of growth here in the second trimester. Pushes up on the diaphragm, makes it difficult for having normal breathing, but they still breathe fine. It's just that an exchange gas, but it's displaced. Respiratory capability changes. So we don't, instead of having 500 being, of 500 cc's of air being exchanged, maybe only get 400. So it was just a number, you get a little bit more than that. So the respiratory rate increases to accommodate the lack of volume. So overall, the blood volume increases because, of course, now we're providing blood to a second body. So eventually increases to as much as 50% by the end of the pregnancy. The number of red blood cells also increases, and the speed of clotting increases, which is good for us. Third trimester, there is an increase in vomiting and potentially aspiration following trauma because of the changes that occur in the gastrointestinal tract. Okay? These changes of gastrointestinal mobility and displacement towards the pregnant woman. So she may not be able to clear her airway even though she needs to, and therefore we need to assist her, be careful of that. The cardiovascular system, we know there are changes there because it increases the demand, needs more oxygen, needs more volume. All these things happen. And of course, some of these things, extra volume and fluid actually go down the feet. We have swollen feet, swollen hands, et cetera, et cetera. Cardiac compromise can be life-threatening if it is too much. Weight gain during pregnancy is normal, but not too much, et cetera, et cetera. That can be cause problems if they have prenatal care. The doctor will be on top of that. Increasing hormones affects the musculoskeletal system by making the joints looser. Looser. So what we can get now is, instead of a fracture, we might get a dislocation. Third trimester, changes the body. The center of gravity has changed. We have this woman who normally walks up straight upright, but now all of a sudden she has this huge weight in front of her that now she's leaning forward or whatever, or she's trying to lean back to extend it. Her balance is off, which causes for possibility of fall, especially in the wintertime when you got ice and all that doesn't help her walk around. Most pregnant women are healthy, but some are not, okay? And then they may become ill during pregnancy, as everyone in the real life world does. You may safely give oxygen at any time for this patient with no harm to the fetus. I don't know why that would be different, but it's important to make sure actually to give extra oxygen, or in a patient where you don't think you'd give oxygen, I would give oxygen if she was pregnant in her second or third trimester. Diabetes develops and goes away depending upon the, what's that? No, just got a cat against me. We talk about some changes, hormonal changes. And if they didn't have diabetes before, they may develop it now, gestational diabetes, and usually it resolves afterwards. So part of your assessment of a pregnant woman is making sure that you are getting blood sugar levels. Hypertensive, okay, hypertensive crisis can really affect a woman and her fetus and fetal. Wow, am I talking here? The fetus. And it's important to get a good baseline blood pressure and see if it's going up or down. And if it is high, you need to ask the patient, because at this stage of the game, they're getting their blood pressures taken regularly at the office, and they should know what their blood pressures are. And if it's higher than that, shows some concern in regards to that. So this condition can really develop in like the 20th week of gestation. And if you didn't know, there's 42 weeks. I think you guys know. All right. Related conditions, eclampsia. Okay. This is typically by seizures that occur. And some of the things that maintain here is that we're going to treat the seizing pregnant woman just as we would do any other seizing person. Right? So we want to make sure that, that they're probably going to be down on the ground. We want to make sure they're on the left side because they're pregnant now. Maintain the airway, administer oxygen if necessary. If vomiting occurs, we're going to suction the area. And this one here is because they are pregnant, we're going to have rapid transport to the hospital. And we may need to call ALS to give medications to stop the seizure if it hasn't already stopped. And a lot of times we're going to give magnesium because that will help prevent the electrical current malfunction of the heart. So we don't have issues with cardiac dysrhythmias for this patient. Transport on the left side. Why do we transport on the left side or the right side? It's because of the vena cava. We want to get the heavy fetus off that vena cava because that can cause hypotension. Right? And it can also reduce the blood flow to the fetus. So we want to put it down, lie her down, left recumbent. Internal bleeding may be a sign of an ectopic pregnancy. So you get a call for a female in her mid-20s. She's got acute abdominal pain. All right. She also may not have any real bleeding, but she might have had some spotting beforehand. You ask her if she's sexually active. She says yes. Is there a chance that you are pregnant? Well, I'm not on any birth control. I might be. In this particular case, or that they're trying, this particular case is that she did get the egg fertilized, but it never fell out of the fallopian tubes and take root into the uterus. Leading cause of maternal death in the first trimester is internal hemorrhaging into the abdomen following a rupture of an ectopic piece. Maternal death, that's the patient dying. The patient dies because of this. So it is a true emergency. Consider the possibility that a pregnant woman, who missed her period, complains of sudden and severe pain. Okay. Hemorrhage in the vagina, hemorrhage in the vagina that occurs before labor begins may be very serious. ALS, you got to give a call for ALS. they're going to need, she needs fluids quickly. There may be an early pregnancy may be a sign of spontaneous abortion or miscarriage. So what happens if it's earlier in like the first 8 to 12 weeks, it may be a spontaneous abortion or miscarriage. If those occur or if it occurs later on, and what we're looking for is we want all the discarded or all parts that came out of the vagina. Why is that important? Okay. Why it's important is because the doctor has to actually examine the uterine wall to see if there's any parts back up in there. Because if they have to scrape those out because they get infected, and you get a PID, and the woman may get septic and die. So you want to make sure that if there is a miscarriage, you want all the parts of that miscarriage to come with you. Right. In abrupto placenta, the placenta separates prematurely from the wall of the uterus. Right. Causing hypertension, severe pain, vaginal bleeding may not be heavy, but that's because the blood's being held back up because of the uterus against the cervix, right? And the patient may experience, heavy bleeding without significant pain with this. So either way, placenta prayer is no pain. Abrupto prayer is with pain. Holy shit. Gotta get moving here. Passage the fetus and placenta before 20th week is an abortion. Okay, may be spontaneous or induced. Most serious complication is bleeding and infection. If the woman is in shock, treat and transport immediately. This woman may need a lot of fluids and need antibiotics. And a woman who's pregnant, increased chances of being a victim of domestic violence and abuse. It's a shame, but that's something that happens, that their spouse abuses them, and there's a lot of arguing. Abuse during pregnancy increases with the chance of spontaneous abortion. So if they've had a spontaneous in the past, or that she goes through a premature delivery, there's an increased chance of abuse. This also contributes to the premature weight of the baby. Women are very at risk for bleeding, infection, and ruptured uterus. Professionalism, environment, privacy, documentation. If the woman is scared and may not be honest with and how the injuries occurred, right? Call the police, have them investigate. Your job is not to investigate whether or not she is or not, but if you think that your patient has been abused sexually, emotionally, you need to report it. You don't have to investigate. We don't want you to investigate. You're not liable for reporting it, but you are liable if you think it to report it. Not report it to the doctor or the nurse, and they will do it because they're mandatory, but you as an EMT are a mandatory reporter. Effects of addiction on the fetus include all those things they list right there. Right? Using drugs, just or alcohol, which is a drug, but it's a legal drug, cause lots of problems with the fetus and the development of it. And fetal alcohol syndrome, as described, low body weight, undeveloped. You know, it's obvious once they come out of it if it's the woman's been lying that she hasn't been drinking when she's been a heavy drinker. All right. Again, this top sign here, pay attention to your safety. You're delivering, coming here for an addict, woman, pay special attention to your own safety. So you're not, you got your back to a wall, or that you got your back to the exit, and not behind someone who's there who may want to think that you have drugs, want to take your needles, et cetera, et cetera. So it's important. Follow standard precautions. Again, eye protection, face protection, gloves. Okay. So a large presence of drug paraphernalia, multiple empty wine and liquor bottles, and statements by the family or by the patient herself even that she drinks heavily. Okay. If for some reason you do have a newborn, it probably will need immediate resuscitation, or I should say, they'll need respiratory assistance and give oxygen sooner than we would if it was a regular delivery. Trauma. You have two patients. Speak to the woman, even if they're minor injuries. Have her talk to her GYN, OB/GYN doctor, nurse online, or medical. They're going to need to get. They should be seen. Period. Whether or not they get in their ambulance and go, that's one thing. But at least they have a plan of action that they're going to see a physician because of this motor vehicle crash and the trauma that comes along with it for the body. So yes, the pregnant woman becomes a victim for many things: assault, and shootings, all that other stuff. Pregnant, increased risk of falling. We already talked that. The reason why they increase the chance of falling because their center of balance is off. Their gravity. They got this extra, 10, 15 pounds of something in front of them, and of course the hormones changes loosen up their joints, and they might not have the ability to be balanced as before. Agile. Some facts and figures here to understand. I'm not really into it that much, but you do know that the pregnant woman has an increased amount of total blood. I mean, 20% increase, and then with that extra blood, it increases the heart rate because it has to pump it all around to not one but two people. All right. So a pregnant woman's trauma patient may experience a significant amount of blood loss before you even detect it. Okay. A concern, that's why we don't like to sign off pregnant females on scene, because we want you to go and get checked out. With that serious trauma and blood loss, again, we're going to get a chance of a lack of blood going to the fetus, and that means we have all types of problems after delivery and for the entire life of that baby. Okay, motor vehicle. How does the woman wear her seatbelt, and does she wear it right? So we're looking at the mode of injury, the mechanism of injury here. Is there severe bleeding because of this? Now, it may cause a proprio placenta. So you may suspect this trauma with abdominal pain, not necessarily bleeding, but again, acute pain in this one. Right? So, common symptoms included in vaginal bleeding and severe bleeding, quick access, transport patient support. So basically what you're doing is treating the patient for shock and transport. We already talked about that and seatbelts. Pregnant trauma patient goes in cardiac arrest, your face or focus will be on her, the patient in cardiac arrest. You have nothing to do with the fetus. Remember that the only chance that you have to save the fetus is to save the woman. Okay? Might be a little bit higher doing chest compressions on a third trimester pregnant woman. Now, this will the second thing down here, perform CPR and provide transportation. I don't know if you know it, but there is actually a different way of providing, or different concerns in providing CPR, basic CPR on a pregnant woman in her third trimester. You should go over that when you do your BLS certification with the American Heart Association. The focus is on the assessment and the management of the woman, not the fetus at this time. Prepare for vomiting, anticipate it, attempt to determine the gestation. So ask them, how long are you? Well, I'm 32 weeks and 5 days. So they actually do it by days, so weeks and days. So it's important to relay that information to the hospital when you give your report. A lot of times, if a woman who is under 20 weeks pregnant, she can go be seen to the emergency room. But if she's 20 weeks or more, she has to go up to OBGYN, cleared by them, and then can come on down to the emergency room to take care of any other injuries. So, why OB is such a specialty. Nothing really changes here on a trauma patient. Airway oxygen, treat for shock, transport, left side. All right, I have not done too much research on the cultural values consideration. The culture sensitivity is important when you're assessing and treating a pregnant woman. Right? Some cultures may have a value system that one has to be a female examiner, not a male. Okay, so choose yourself very carefully. So on that, if they how they plan for their the process. There's a lot of things that go on with different cultures on that. Be sensitive, try to abide, but when it all comes down, the patient, the pregnant woman, needs to be taken care of properly and got to the hospital. Some cultures do not permit male. I said that, especially in the pre-hospital setting. Assessments and examination by female patient. So they're all looking for a female in regards to that. You should respect these differences and honor the requests from the patient. Your responsibility is to the patient, and it is limited to providing care and transport. So if she's refusing to have you treat her, then but allows you to transport her, then you go along with observing what is, get some vital signs, and based on the patient's culture, examination is limited to visual. Very important topic to bring, because then the ED can get things ready to go. Teen pregnancy. Again, we talked about that question. Do you really want to ask whether or not a child is pregnant in front of the parents? Wait until you get out in the ambulance, or have the parents go in the other room, go get you something so you can ask the teenager point blank, hey, I need this to know so I can treat you appropriately. All right. Seldom is, Seldom is unexpected. You know, the woman who's pregnant doesn't know it supposedly, and all of a sudden she delivers a baby in the toilet. And oh, I didn't know that I was pregnant. Yeah, right. Okay, what'd you do for the last 9 months? And you know, yeah. So it does happen. Simple questions here we don't know is from dispatches whether the birth is imminent, and so therefore we might need additional help. You got 2 patients now, 2 ambulances, 2 ambulance crews. It's important. Glove and eye protection because a delivery is not necessarily a clean operation. Blood is splatting or splatting around or gets tossed around, so you don't want to be having that in your face. Gowns are very nice. Try to provide a relaxed environment for them. Know what's in your OB kit. Mechanism of injury. Ask the woman if she fell from standing or tripped or something. Ask some of these questions here. You know, did they have a vision problem? Did you have tunnel vision? You know, what all these different spots in your eyes? All these things are normal in pregnant women at times. General impression. Active labor. What is active labor? That's when the contractions are a sustained period and repeat themselves. They're beginning to determine that the pregnancy is immediate. It's going to be coming along soon. So you need to prepare. Perform a rapid examination of the patient, and that means an actual visualization of the vagina. See if it's crowning already. Take a moment to perform whether or not the fetus is delivering in the next few minutes. Yeah, as I said. Evaluate first. So you gotta get the woman positioned in the proper place where you can do the delivery comfortably and get the necessary sterile items out of your OB kit. Uncomplicated, which most of them are, high percent, very few percentage of deliveries is complicated. Airway and breathing is not an issue. Motor vehicle crash, assault, all that stuff changes things. You have to do a better assessment on that. We've beat this dead about bleeding, but check for a pulse. No, do your assessment. Get your set of vital signs. Transportation. Hey, if immediate delivery, you're not going. You're going to do it there, unless you like to try to deliver a baby in the back of a moving ambulance. I've done it in the back of an ambulance, but not necessarily moving. We're all stopped. And so, what's better? You know, the environment you're in or the back of the ambulance. You might be able to get the patient to the ambulance and do it in the back of the ambulance where you have, you know, the walls that and privacy and can work on your equipment's right there versus, you know, on the floor of a office, you know, building, you know, things like that. Now, here's the time to put the lights and sirens on if there's significant bleeding and pain, hypertension, patients having a seizure, ask for ALS intercept, and ultimental status. And this is a time when you can, a true emergency, you're not going to be able to stabilize the person at this point. So just get them and we'll treat, or we'll go and treat while we're in the ambulance going to the hospital. History of the mother, this pregnancy, a protective history. You want to know if there's any prenatal care, that's for sure. You want to know when the due date, you know, are we dealing with a baby that's 30 weeks or a baby that's 38 weeks? You know, we're looking at 38 weeks, you're looking for a full term, 30, 28. We're looking for a preemie, which is going to be more difficult, need more things. any complications that she had in past deliveries. How many did she have? How many times has she been pregnant, and how many times did she do a delivery, and whether or not they were vaginal or were they C-section. Complete medical history. So there's a lot of questions being asked of the woman who's panting and in pain. Sample, okay? Secondary assessment. Systems. Know what's going on. How's the respiratory? How's the cardiovascular system going on? Are we getting swelling in the feet? Are we getting swelling in the hands? You know, assess for fetal movement. Is the baby kicking and moving around? Good sign. You know, not too many, if any, you know, carry Doppler to actually understand whether or not the baby is being has a heartbeat, and give you a digital readout to see if the kid is in danger. Vital signs, all the other stuff in vital signs. Let me see, am I supposed to do something here or what? I don't know. All right.
I'm sure that Ashley can attest to this, but when you ask a woman who's having contractions questions, give her a few minutes to answer, because it is very hard to catch your breath and talk when you're in that rush of pain.
I find her very non-compliant in answering let me answer questions here. What's the story, lady? That's a very good point to put out, because people who are in that much pain, but also trying to breathe to ease this process. You're absolutely right. Thank you very much for chirping in. Appreciate that. So the blood pressure is going to drop slightly during the second trimester. So therefore, if we have a hypertension situation, that is something to be noted and passed on to the doctors. Hey, her normal blood pressure during pregnancy has been about 150 systolically, and then all of a sudden now it's 200, 250. Major indication that we need to immediately get ALS or get this person to the hospital. Keep on repeating all those ABCs, you know, as we go along here. Early recheck, see how the person is going. When when childbirth is complicated by trauma, all the interventions need to be provided for is to treat the patient, not the fetus. But you have to think of it as benefiting the fetus also. Communication, documentation, pre-notification, the hospital as much as possible is very helpful. Documentation is what you observed, what you did, and any other current facts. No opinions. It's a rare occasion that the placenta will be delivered about 30 minutes thereafter. That's all part of you. Okay, you're waiting on scene. You got the baby. You got two crews, one taking care of the baby, one taking care of the mother, and the person is still there waiting to catch the placenta. Do not pull on it when it comes on out. You're going to want to put it in a Ziploc bag, which comes with the OB kit, so they can examine that at the hospital. So staff will want to know all about the number of weeks, due date, and any complications of previous pregnancies or during this pregnancy. 3 stages: one is the dilation of the cervix, then of the fetus, and third, the delivery. All right, so hopefully you'll get to the patient during the first stage of delivery, right? And this birth. As long as it lasts up to 16 hours, you can get the woman and her fetus to the hospital without any problems. You know, talk about contractions of the uterus. What we're looking for here, information. How often and how long are these contractions? Those are things, the intensity of these things. Okay, labor generally longer in the prima graphida, no, gravida. So this is the delivery. This is how many babies. So labor is generally longer when the woman's having her first pregnancy versus her multiple, second, third. She says, hey, this is my third baby, and the last one we delivered, you know, I just barely made it to the emergency room, and we delivered. And expect that, hey, it was that quick, then we're going to be as quick, if not quicker. So we're not going to get there to the hospital in time. We're going to actually do it. The experience of preemie or false contractions called Braxton Hicks contractions. You should provide transport for the patient to the hospital. You can't determine that. Let the doctors and the OBGYN nurses determine that and tell the woman that, okay, you gotta go back home. Here is a table. I don't even care to review it because I'm not going to actually know it or do it for the contractions. Someone experience premature rupture of the membrane, right? But that's important to know. It doesn't mean that most of the time it means the delivery is coming imminently. But it can be, and it can be up to 24 hours. But usually when it ruptures, they will go to the hospital and they'll be in the hospital until such time as they do that delivery or they induce delivery on that. Second stage really begins when the fetus begins to encounter the birth canal and ends to the delivery of the newborn. Okay. So during this section, and I'm sure there's going to be a test question somewhere along the line. What's the first, what's the second stage, and third stage of delivery, and what is the body doing? What is the fetus doing during those stages? During the stage, you'll make decisions about helping the woman do the delivery at the scene or provide transport to the hospital. Uterine contractions usually closer together and last longer. Under no scheme should you let the woman sit on a toilet. Why? Because she'll deliver the baby. She spreads the pelvic cavity, easier for the child to be delivered, and you don't want to deliver a baby in the toilet. Okay. The perineum will begin to bulge, right? And significantly. And this is where, you know, we have we already talked about the skin between the vagina and the anus, but this is starting to bulge, and the head's going to start to show and appear, and we call this crowning. Okay, so you're going to have to do a visualization of the vagina to see this. Begins with childbirth, newborn, ends and with delivery in the placenta. So this third stage here is the delivery begins when the birth of the newborn, and it ends with the delivery of the placenta. During this stage, the placenta must completely separate from the uterine wall and may take up to 30 minutes or less, okay? Do not yank on it. Do not pull on the umbilical cord. Prepare, you know, I try to do a sterile environment as much as possible. Your OB kit has sterile gloves, has sterile drapes, things like that. And natural disaster, inclement weather, and other environmental factors make it impossible to reach the hospital. You're going to do the delivery. Okay, where was okay. Determine if it's in it. We already did that. But again, how long, how far apart? And how long are the contractions? Any spotting? Do you know if the mucus plug has been removed, if it popped out? Any bleeding? Water broke? All this stuff, infant bowel moves. She feels like there are times, when she is trying to push and she may have a bowel movement during the delivery. That's why we put certain sheets. If it has a bowel movement, put another sheet over, a sterile sheet over that, so that the child does not get contaminated. Again, how was your previous delivery? If you more, how long did it take? Any problems? We already answered the drugs, alcohol, medicine, street drugs, all these things. How many multiple births? There's a lot of questions to ask. There's nothing wrong if the husband's there. Let's ask the husband. It'd be nice if we have a significant other there to answer some of the questions. It's emotion. The woman is trying to breathe through all this pain from the contractions. She really doesn't want to answer all those questions if you can help it. So she feels like she needs to move her bowels. That's the indication that she's going to deliver. Inspect the vagina, check, see how the crown is coming along, and I hope you're ready with your kit and help. Once the labor begins, you can't slow it down, you can't stop it. It's coming. Never attempt to close a woman's legs. Hey, Kim, close, we gotta go to the hospital. Kim, it doesn't work. Okay? And again, don't let her go to the bathroom and all that stuff. It's a good little question there on number 5. Remember, if you're delivering at the scene, you are only assisting the woman with the delivery. She's doing it all. You're just making it, helping out to make sure it goes nice. Know what's in your kit. Get an expired one, tear it apart, look at it. So the first time you're in a stressful situation with delivering a baby, is not the first time you've seen this kit. Each kit is a lot different in regards to it. It all depends on what the ambulance company wants to get for a kit. But these are basic stuff here that are required. Surgical scissors, a scalpel, umbilical cord clamps, tape, tie things off, small rubber suction tubes. So it's not a big 3 cc bulb, so it's like a 1. You need towels and you need drapes and you need sheets to go over that. You're going to need some gauze, probably, sterile dressings, infant blanket to keep it, because that's the number one problem we have after the kid is delivered, is that we need to maintain their body temperature, okay? And an infant-sized BVM and goggles. Infant size, that's neonate-sized BVM. Should be on your ambulance. If it has been there, you need to check to make sure the mask hasn't collapsed on it. That's because it hasn't been used in 10 years because no one done a delivery in that year. Okay. Remove the clothing should be removed and pushed away from the waist and the pants, and undergarments, everything removed. Try to do a little privacy as much as possible, but you can remove the clothing, as you can remove the clothing up above and just cover the top. Later on, she might, if you deliver or when you deliver, you put the baby on her chest, and the sucking of the baby or nipple will help with the child. All this stuff you're looking at, you got blankets, you got pillows, you got, takes a lot of stuff. Did you bring it with you in? No. So those are things that you might have to go back out. Okay, here's showing 2 pictures. A woman starting to be draped. We have sterile drapes over each thigh, one over the top, and they're going to have, if you don't see it, the blue one is another one, so we have one underneath so we don't get everything all wet. But you should have another one there. Again, I talked about fecal being excreted during delivery maybe, and you want something to cover up that so you don't get the baby touching that stuff. So you got one at the heads, reassuring, the other one's down below. Patient needs oxygen, give them oxygen. You need to be in position to see the perineal area all the time. Once you've come to this point, you've made that decision. We're going to be there. Call for additional help because you're going to have another 2 patients, and you're there for the whole road. Reminder about breathing. We just talked about that, how the woman's not going to be able to answer questions when she's just trying to breathe through the contractions. Apply gentle pressure across the perineum with a sterile gauze pad to reduce the risk of perineal tearing. So the baby can come out so fast and violent that it can actually rip the perineum all the way back to the anus, where she's then going to have stitches put in. Be prepared for possible patient having a bowel movement. I already talked about that. Be careful if you poke your finger into the newborn's eye or into the fontan. Well, I don't know why you want to poke anything in the eye, but the fontanelles might be of concern that you don't want to do. Be careful on doing that. Okay, the rare occasion that the amniotic sac is not ruptured during the beginning, you need to break it. Puncture it with a clamp or tear it with your fingers. If you're drilling the baby and the cord is around the neck, you need to gently bring your finger underneath that and loop it up over the kid's head so it's no longer there. It's commonly considered a notchable cord. It would be tightly around the neck and could strangle the fetus. That's why we have to remove it. Do not cut it. If for some reason you cannot get that, what's the other option? If you're unable to get that umbilical cord that's wrapped around the baby's neck tightly, the only option is to cut it. Not a good thing to do at that stage of the game because the baby's now going to lose out on blood, nutrients, and you got to deliver ASAP. But if you do normally, once the baby's out, then we can go through the process of cutting the procedure. But basically, you're going to take the fetus, now that neonate, and grab it, place it up on the mother's abdomen. It keeps it warm, good place to stay, but make sure someone is making sure that baby doesn't roll. You have drying the baby off. Someone else is going to be drying the baby off, stimulating the baby. And 1 minute after delivery, you give your first APGAR score rating, and you do it right by the chart. Should be in the OB delivery kit itself. Should be a chart with all the information there for you to check off what it was and the particular time. And then you do it again 5 minutes later. So as you're delivering, once the head comes on out, the head's going to rotate one side or the other. It doesn't make any difference, but it's naturally going to rotate. And then you're going to support the head. You're going to assess for the cord around the baby's neck. And then you're going to slightly, as the patient is being pushed further, you're going to lower the head down to assist in getting the anterior or the top shoulder out, and then vice versa for the left shoulder, whatever, the top shoulder and bottom shoulder. and the baby will rotate again a little further as it comes on out. Please do not drop the baby. Moms get upset over you drop kicking their newborn baby. All right, post-care. Mother is able and willing, and hand the newborn off to her, placing the newborn on her abdomen, skin-to-skin contact, all good. Make sure the baby's dried off, stimulate that, so the baby will start to breathe and cry a little bit, whimper a little bit. But it's important now to make sure you get the body and the head covered. Once you do with one dry, one rag, put another towel over there. And you can actually put the child in one of these swaddlers, which are aluminized after you remove the excess fluid from the child's body. Right. So place the newborn on one side with the head slightly lower than the rest of the body. Okay. Now, you haven't cut the cord yet, so you really want to make sure that you keep the baby at the level of the mom's vagina or heart, all right? So, or a little bit lower. So once you got all this, the baby is now wiped off. If there was a little gurgling, you could do a little bit of oral suctioning with a bulb syringe. And this stimulation should get the baby crying or at least breathing for you. The umbilical cord is still pulsating. So what we're going to do is we're going to keep the baby lower than the vagina, and we are going to get ready to clamp the cord. Once the cord stops pulsating, you can now squeeze your finger, like in between a straw, and push the additional fluid back towards the baby, and then you can clamp that area at least, like 12 inches, who knows, but 7 to 12 inches away if you can from the baby. Another, 4 or 5 inches in between, and clamp it again, and then you can cut the cord. We're talking here about the mom and bleeding post delivery. Some bleeding may lose up to 500 mLs. Again, a reason for IV and for fluids for ALS to show up. Wrap the entire placenta in the cord after you delivered it. Again, it has to be brought to the hospital for examination. Right. Put a little bit of sterile, tampon, not tampon, but napkin or 5x9 in between the woman's legs and transport. As you're transporting, you're getting the woman, you want to start circulating movement or kneading the font. Excuse me, I'm having a brain cramp here. You want to circulate motion of the massage and gentle massage the font of the mom so that it will now get softer and softer, and that kneading action going on. You should be able, it's about the size of a grapefruit, but you should be able to get that fontanelle or feed fontaise down. Record the time of delivery. 30 minutes elapsed, you should get the complete placenta delivered. All these things come in play. If they exceed that, you'll have to think of it as a true emergency and get the woman to the hospital as soon as possible. That's a licensed siren job. All right. Keep on going here, Dave. Okay, neonatal resuscitation. There's a class in that, a little bit beyond your scope of practice when you become an EMT, but it's a real nice class. A newborn will usually begin breathing within 15 or 20 seconds after birth. So they're not breathing for about 15 to 30 seconds. Okay, So you get time there, but that's why you're rubbing them on and off. And the heart rate is at about 120. So think about how you're going to measure that heart rate. Are you going to be able to feel that? You're not going to get it in like your at the wrist. You're not going to get it in your arm. You're going to do apical. That means over the heart, one, or you can have a device, SpO2 sensor that will help pick it on up, and that would be placed over the entire foot or entire hand on that. So some newborns, or as they say, many may require some stimulation. Again, that's rubbing the baby, keeping them warm, and a little tactile suctioning. But make sure you position the airway. They have a very flexible airway that can be blocked very easily. So if you hyperextend, you block it. If you hypoextend the neck, you block it. So you got to get it in that sniffing position for the baby to be able to breathe. Yeah. You can look at that table later. Position, basically maximize the effect of these measures. Towel, blanket, all that stuff, you got to bring that in. All right. Suction may be needed in the mouth and nose. Again, suction mouth, then suction nose. You can do this with a soft suction catheter or a bulb syringe. Avoid deep suctioning. Why? Because you stimulate the vagus nerve, which actually stimulates the lowering of the heart rate of the patient. Babies, newborns do not normally need oxygen. If anything, it'd be a blow-by, but you do not. You'll get that off of your vital signs, but they don't need oxygen right away. Room air is fine, and if you had to BVM, you can do a BVM without the oxygen initially. All right. Now we are taking care, or someone taking care of the newborn. Spontaneous skin color, movement, all that stuff. Evaluate the heart rate. We all talked about that, the APGAR score 1 minute after delivery. Okay. Heart rate is an important factor here in whether or not you need resuscitation. Okay. We also want to know whether or not the color, when we get into the APGAR score, we want to know if the color the baby has blue feet, but pink body, or pink feet, pink hands. I mean, blue feet and hands, or the baby's totally blue. Depends on those criteria whether or not we just stimulate them, let them get 30 seconds or a minute under the belt of breathing to bring that back on up. Are they starting to perk? They didn't need anything. If they're not perking up, then we have to give some oxygen. If they're not breathing, then we have to breathe for them and do CPR. But we'll go with a heart rate on that. So you're going to need means of obtaining. How are you going to do that? Additional neonatal resuscitations. That is neonatal resuscitation is almost never done pre-hospital because they know that the mother and child are having difficulty, and through examination they're going to be in the hospital. We do not normally do that pre-hospital, even on the rare occasion that we actually do a delivery. Chest compression is required during the circulation. So you know that basically the same thing in your CPR, American Heart Association. Note here, what is the ratio of compressions to the ventilations? 3 to 1. 3 to 1. So in that particular case, you can't physically do the ventilations. You're going to have someone else with a bag there, and probably best if you had to do CPR, you're going to want someone there to hold the head in a neutral position while holding the mask, and only a second person squeezing, and I say squeeze, the BVM with 2 fingers. No hand, just 2 fingers, and squeezing that. And we all know that that is done as soon as we get rise. A little rise out of that, that's enough. Don't even go any further. Okay. Any newborn who requires more than routine resuscitation needs to be transferred to a level 3 or greater neonate intensive care unit. Dartmouth or Portland. Okay. Even though Portsmouth Hospital is a level 2 trauma center, they are not set up for neonates. They ship them out. So in our particular case, we're looking for maybe actually went with Douglas in Dover, 10 miles up the road, which is a level 3 neonate intensive care center. So those are things to think about. Now, I talked about this mucin mucotum staining in the fluid. Is there any, you're going to look, visualize, is there any in the nasal passageway or the oral passageway of the baby? So there's going to be some initial suctioning that may be done on that. There are some pros and cons in regards to how that is done, but you're going to have to go by the local protocol on what you're going to do. Are you going to do, which you can't do as EMT, is deep suction with a soft catheter, suction catheter. You'd have to have a medic there for that. But it's something that may or may not be needed down. Your bulb syringe is probably all you really need. We already talked about APCOR, and you're gonna have to look at the form there. Okay, appearance, pulse, grimace, irritability, the activities of the muscle tone, and respirations. That gives it, writes it on off. Perfect is 10, not going to happen. Kelly 1 to 5, and so here is a score sheet how it's done, and that's done 1 minute after, and then done another 5 minutes after that. And if you're transporting now to the hospital, you should be giving them that APGAR score. And they might actually ask you to break it down into A2, A1, or P, pulse 2 or 3, or not 3, but 1 or 2 or 0. So they might want to actually know where is the problem on that. Follow the outline, look at it. You should request a second unit as soon as possible. Okay. Anytime you're going to do a delivery, now you're going to do patients, ask for a second. And if you're not ALS, an EMT and a paramedic, call for an ALS unit too. Gentle pressure, if you're doing ventilations, keep note there. You can easily overinflate these lungs. Think how small these lungs are. Do not overinflate them. Okay, so complications come about. Breech delivery. Well, a breech delivery is presented when some other portion besides the head is coming out. Right? And it might be, a buttocks sticking there. Might be an arm or a leg. Okay? The fetus is at risk. Okay, and prolapse cords are most common in a breech delivery. Now remember, if you have this prolapse cord hanging out, this is one of the things that happens where they tell you can't do it, but now we want you to do it, and that is insert your hand against the head and take the pressure off the umbilical cord. Of course, we're also going to get the patient's knees to chest to get her back up out of the way to try to open up this area a little bit more. Breech deliveries do take longer, okay? And also enough, since it's going to be longer, you might have the time to transport the patient and the fetus to the hospital. So the buttocks are not. If you get buttocks showing, they're not coming vaginally. So whatever you like to do, you're not doing it at home. You're gonna do it at the hospital. Okay. Okay. So how are we treating this? Position the pregnant woman, prepare the O kit, place yourself and your partner in appropriate position, allow the buttocks and legs to be delivered spontaneously. So you can get the legs to come on out and still deliver. Sorry. A limb presentation cannot be successfully delivered. So if we have a foot or buttocks, we can possibly deliver the kid. But if it's not just a limb, need a surgeon. And we know where that surgeon is. Again, patient on their back with the head down and the pelvis elevated. Right. Never try to push the limb that's protruding back out, but placing the patient on our back will help elevate the pelvis and get the pressure off of the umbilical cord. Come on. Okay, keep going here quick. Okay. Prolapse umbilical cord where the umbilical cord becomes out of the vagina before the fetus. Okay. So you're en route to the hospital, it's one thing. If you're not, you're there, you decide to do a delivery there, and all of a sudden, hey, instead of getting a head coming out, I got the umbilical cord. The head of the fetus will compress the cord. Okay. Therefore, what doesn't get to the baby? Oxygenated blood. Okay. So you can't push the cord back in, but hopefully there's enough time to get to the hospital. But you want to really keep the fetus head from compressing the cord. So this time here, I'm going to want you to put your hand on the kid's head. So place the pregnant woman supine with the feet raised, inch away, hip, elevate the pillow, fold the sheets, alternate the woman in places of knee to chest position. Okay. Carefully, so you don't touch the font, anterior or posterior fontanella of this infant. You don't want to put your hand into the kid's brain. Okay. Is that you place gentle pressure on the head and away from the umbilical cord. And once you do that, that is your position until you get to the hospital. Right? You don't take your hands off. You don't push the head all the way back in. Just get enough pressure off. Spinal bifida, that's basically where the spine column comes, the spinal cord comes outside of the spine. Very difficult. I don't think you ever really see that, but that's what it is. I've never even heard of that being delivered pre-hospital or something like that. But you do cover the spinal cord with a damp, sterile solution and transport. Multiple, twins, all right? Every 30 births are twins, wow. Usually multiple births are diagnosed early and the person is actually going to be in the hospital and they do this by C-section, or at least they'll be in an environment close. You're not going to actually get a chance to deliver that unless there's some malfunction down the line, a natural disaster or something like that. But consider the possibility of twins if she didn't know it, if you have a very small baby and the woman's very large abdominal cavity there. And then, of course, you're going to wait until delivery of the placenta. if the second one is born within 45 minutes of the first. So that's interesting to rethink. Okay, I'm here. I delivered the baby. I'm waiting 30 minutes, up to 30 minutes for delivering the placenta. Okay, but now this woman is having a twins. So if twins are presented, the second one will usually be born within 45 minutes of the first one. So we're doing 30 minutes for the placenta, but now we have twins that have 45 minutes. This is a long on-scene time, folks. You're going to have to justify this in your report. About 10 minutes after the first birth, contractions will begin again, and the birth canal will repeat itself. Okay. And so, proceed delivering twins, same in the first. Get a second OB kit. All right. Clamp cut on each one. Preemies, not full term. All right. I don't know why they put these babies' weights in pounds. That's not how it goes. But single birth newborn will weigh approximately 7 pounds or more. Any baby delivered before 8 months, it's before 36 weeks or less than 5 is considered a preemie. So the weeks are what you want to know. How many weeks are you pregnant? When's your due date? Are you 35 weeks or are you 40? Makes a difference. Everything's smaller than a newborn. The delivery itself is going to be the same, all right? But it's very, very important for this preemie not to have any body heat loss. Jack the heat up in the back of the ambulance. Make sure you have warm blankets if you can possibly do that. Something. You do not want that child to be hypothermic when he comes into the emergency room. You're going to get your butt chewed. But you can also be very hard on the newborn and cause additional problems. So. Wow. Special care for twins, of course. Postpartum fetus can be larger than the typical 40-week fetus, sometimes weighing up to 10 pounds. This condition can lead to problems with a woman and fetus. It's more important, a more difficult delivery in this twins. All this stuff, increased chances of injury, likelihood of C-section. We're not doing that, folks. Just let you know, we don't do C-sections in the field. The peritoneal tearing, which causes infection. Sometimes rubbing the cervix as the opening of the vagina with a little lubricant, just as getting ready to deliver, can help stretch it out and not rip it. But you're not supposed to do that. You should be prepared for resuscitation. So as you're dealing with all this going on with delivering, you're taking care of the mother, getting ready to deliver this baby. Oh, by the way, you got to be prepared now in case the infant now needs resuscitation. So you got to have all that. There's a lot of stuff to pull out and get ready and be around somewhere. Need more hands. Fetal demise, a very sad situation. The fetus dies in a woman's uterus before labor. Most of the time, they're actually going to know that before that, but it still doesn't make it any easier. The emotional factor of all this is horrendous. The social workers from the hospital need and will be in place on that because if they knew about it being dead and in her abdomen, and she said, well, just to bring it to term instead of doing an abortion, It's difficult. It's very difficult. So onset of labor may be premature. Okay, otherwise progress is normal in the cases, and you don't necessarily know the cause of the demise, but that just lets you know there's going to be extreme foul odor, discoloration, sloughing. The skin may have blisters on it. You know, the head's going to be soft, maybe grossly deformed. Do not even think of resuscitating this thing. And I shouldn't say thing. This fetus, it did not make it. Okay, delivery without sterile supplies, rare, do what you can in regards to that, improvise. Okay, as soon as newborn is delivered, wipe the inside of the mouth with, this is a finger, that's still part of out of hospital with no sterile stuff. Postpartum complications, again, excessive bleeding. A woman can bleed out. So it's starting to get some bleeding in. You can't control it with massaging of the uterus, of the fontanelle. Then you need to get ALS there, IV fluids, and transport, because the only way you're going to save this woman is in the operating room. So again, here, do not, you change the pads off, but don't lose them. Don't throw them away, because they're going to, hospital person are going to see, well, is there a little bit of blood on it? But you can bring it on in, it's totally soaked. I guess they don't take your word, but that's the way it is. Save any tissue that may have came out. That's important, so they can plot this all together and see if all the uterus, all the placenta is out of the uterus. Very the fetus, I should say that the placenta is very vascular, bleeds, but also takes in and can get air embolisms, which can be fatal. So usually, again, talk about clots and things like that going up and creating respiratory, if not cardiac issues or brain issues. Nothing you can do there, just transport. If you think the woman's starting to have a stroke after you're delivered, you treat it like a stroke patient and you get her to the closest hospital and let them do the thinning of the blood or go back on in. Not a primary, but a comprehensive stroke center would be best. Okay, we're all done here. We're doing a little bit of review. So the first stage of labor ends when? Anyone?
A.
Thank you. How many people do we have now with us now, huh? Hey, I talked to you about, you got to learn those particular stages. What's first, second, and third stage and what's going on. 23-year-old woman here who's 24 weeks pregnant, her first child, complains of edema in her hands, headaches, visual disturbance. When you assess her vital signs, you note that her blood pressure is 160/94, and she's most likely experiencing what?
Preeclampsia.
You are, yes. B. You're transporting a woman who is 8 months pregnant, okay, viable baby. To prevent spinal hypotension syndrome, how should you position this patient?
D on the left side.
Correct. Immediately after delivery of an infant's head, you should what? Don't get ahead of yourself. We have been crowning. Now we have delivered the head.
Check the position of the umbilical cord.
Correct. We gotta go. I know we want to think about suctioning the mouth, nose. No, we got to make sure that umbilical cord is not wrapped around the child's neck. Upon delivering the baby's head, you note that the umbilical cord is wrapped around the head. You should do what? Anyone want to take a guess? What are you going to do? You get this cord wrapped around the kid. How are you going to get it off?
Well, you're going to attempt to slide the cord over the head.
So that's going to be make one attempt to slide the cord over the head, which is B. Right. We're not going to cut it, you know. You already know that one, right? The need for an extended of newborn resuscitation is based on what?
The newborn's response to oxygen. No, wait.
No.
D.
Right. We're doing this immediately, so we're not waiting the 1 minute for APGAR scoring, because we're going to do this 1 minute later is too late. You should be, newborns are reassessed every 30 seconds, believe it or not. So we want to deal with the respiratory effort, heart rate, and color. And if we can get the stimulation and get the baby breathing and the heart going, we'll be all set down the road. Very good. 1 minute APGAR score on a newborn reveals that the baby has a heart rate of 90 beats per minute, a pink body but blue hands and feet, and rapid respirations. The baby cries when the soles of the feet are flickered. All right. Resistant attempts to straighten out legs. You would assign what type of APGAR score to this? So 0 to 2 is yours. So let's look at it and think and try to remember what you got there. Is for appearance, the body is pink and blue. So that's going to give you at least one because the whole body's not pink. Rapid respirations. Right? That's good. So that should get 2 out of that. Strong cry rate, stillness, pain. A 2.
That's a 2.
Right. And then the legs, you resist on that. So now we're looking at 2, 8, about 8. 6, I don't know. I'm going to go 8. And so, and realizing this, you can't really do this all by your head. You know, that's why I said you should have a card in the first aid kit. Tape it to it if you want. I don't care if the outside, if it doesn't come with the inside. And C is the answer, correct. So again, if you're on the ambulance service, nothing wrong with make a nice APGAR score sheet with the patient's name, date of birth, time of birth, and location of birth, and then have your APGAR score down below with a list, so you can just go across, okay, this, and then you put a number, and then you do the same thing, going across the same thing, put another number, and then you calculate the bottom. Most effective way to prevent cardiopulmonary arrest in a newborn is to. What do you do when the baby first comes on out?
C.
All right, we stimulate here, so we ensure adequate airway and oxygenation ventilation, because most kids, the problems before they go into cardiac arrest, it's respiratory in nature. So oxygenation ventilation is the most important thing right at the bat for a newborn. And While assessing a woman in labor, you visualize the vagina area and you see an arm protruding from the vagina. She tells you that she feels like she has an urge to push. You should what? Shake the
A.
kid's hand? I think you should shake the kid's hand, tell him thank you very much, and go back in. So if it is an arm, that's not feet, but it's an arm, you're going to cover it, sterile, and transport. We don't want her to push. Right. Last but not least, newborn is considered to be a term if the birth is after X number of weeks and before what?
C, 38 and 44. Is that what that says? No, 37 and 42.
Well, C says 38 to 44, but I think if you think about it, actually,
It's B, 37 and 42.
right, because then you get into the late gestation.
Sorry, I'm having trouble reading the slide.
Yeah, it is B. All right. So, as we've gone all through that, we are done, folks. So I have 1, 2, 3. So I got 4 people hanged out. That's good. Thank you very much, and we are done.
Thank you. I really appreciate it.
Thank you.
Take care.